Doctors, we are live.
Good evening to everybody. At the outset, I like to pay my respectful pranam to Chief and Madam, Dr. S.S. Badrinath and Dr. Bashanti Badrinath. And without them, we won't be able to be here today. And whatever we are today is due to Dr. Badrinath and Madam Dr. Mrs. Badrinath. And I have talked with Madam about 2 days back about the SN alumni, and they wish all the best for our SN alumni. Today we are having the Uvea and Retina capsule, and most importantly, SN alumni oration is there by Dr. P. Namparamal Sami of Arvind Eye Care System. We'll straight go to that Uvea capsule, and my colleague Dr. Arshi Ahmed will be take over and will be moderating. I'll stop sharing.
Thank you, sir. Shall we begin, sir?
Yeah.
I'll just share the screen. Is my screen visible, sir?
Yeah.
A very warm welcome to all of you. At the outset, I would like to welcome our panelists for the Uvea capsule. Today, we have been joined by Dr. Manisha Agarwal, Dr. Shishir Narayan, and Dr. Suchitra Pradeep. I would first like to introduce Dr. Manisha Agarwal. She heads the Retina and Clinical Research Center at Shroff Charity Eye Hospital in Delhi. She's an ex-VR fellow from SN. Welcome, ma'am. Next, I would like to welcome Dr. Shishir to the panel. He's an ex-VR fellow from SN Chennai and also holds research fellowships in uveitis from SN Chennai. He is at present working as a consultant at Shroff Eye Center. And I would also like to welcome Dr. Suchitra Pradeep. She is our senior consultant from the Department of Uveitis at SN Chennai. So the capsule will go as follows: that we have an array of 3 cases to be presented by 3 speakers. At the end of each case, I would welcome the panelists to give their expert comments. So is my screen visible, sir? Because I am not able to see my screen.
Screen visible. Suchitra Pradeep's presentation is only name is seen below. Yeah.
So first up, I would like to welcome Dr. Risha for her case presentation. Dr. Risha Jitesh is a consultant ophthalmologist at Little Flower Hospital in Angamali, Kerala. Dr. Risha, I would like to hand over the presentation to you now.
Good evening, all. Hope I am visible and audible.
Yes.
Good evening. At the outset, I would like to thank the organizers and Dr. Vishwas for giving me this opportunity. Today, I'll be presenting a case of an unusual combination of uveitis with the retinal vessel occlusion. This 15-year-old girl presented with the left eye superior field defect of 5 days duration. She also had pain and redness in left eye. She didn't have any history of ocular or systemic illness prior to this episode, and she was given IV methylprednisolone for 3 days and oral stim elsewhere. On ocular examination, her right eye was normal with 6/6 vision. Left eye, she had 6/6 blurred vision. IOP was normal. Anterior chamber showed grade 1 cells. Fundus examination, again, right eye was normal. Left eye, there was grade 1 vitritis, especially localized in the inferotemporal quadrant. Disc margins were blurred, and there was a 2-disc diameter retinochoroiditis patch in the inferotemporal, along the inferotemporal arcade, close to the disc with surrounding vitritis. OCT showed hyperreflectivity of inner retinal layers with retinal thickening and minimal shadowing also. Fundus autofluorescence, there was hyper-autofluorescence, and in FFA, there was branch retinal artery occlusion in the inferotemporal quadrant along the retinochoroiditis patch. HFA showed left eye superior field effect. Provisional diagnosis of retinochoroiditis, probably toxo, with BRAO was made. All blood investigations were done except toxo IgG positivity. Rest of the investigations were within normal limits. Already she was on oral steroids, so we started Bactrim DS for 6 weeks. Initially, patient had a good response with the treatment, but by 6 or 8 weeks, again the lesion showed increased activity with vitritis. OCT also showed increased activity by 6 to 8 weeks. So we changed Bactrim DS to dalacin C and azithromycin along with oral steroids in tapering doses. Now, just 1 week prior, she came after 12 weeks of treatment with the 6/6 blurred vision. The retinochoroiditis patch was almost healed. There was a membrane overlay. So my questions are, is it toxoplasmosis itself, or why it was not responding to the standard treatment initially with Bactrim DS? Is it because patient received a course of IVMP prior to that, and how to go further? Thank you.
Panelists to go over this case and give your comments.
Dr. Risha, it's a very interesting case, and definitely the clinical picture is zone 1 toxoplasmic retinochoroiditis by the clinical picture. Probably we are not having too much of vitritis because the patient has been treated with steroids. Generally, what happens is you try the anti-toxoplasma treatment first, and then you move on to adding steroid. But maybe because it is in right next to the center of the macula and along one of the vessels is involved, you have been lucky if the steroids have started early on. Dr. JB, can I share a few slides, just a few slides of my case of toxoplasma of a similar situation so that we can then discuss beyond? Yeah?
Yes, go ahead.
Okay. So I took out a patient from my own patients, and this is a patient who has a zone 1. Can you see my slides?
Yes.
So this is how it started, as a very small innocuous looking inflammation. You can see on autofluorescence that the area of the inflammation, there is leakage from the disc and there is inflammation of this blood vessel wall. When the anti-toxo treatment was given, an epiretinal membrane and a thickening of the posterior hyaloid developed, very much like Dr. Risha's case, and a bit of temporal pallor developed. But what is very interesting in this case is that the localized posterior vitreous detachment due to the inflammation kept on getting thickened, and there was a huge epiretinal membrane or thickened posterior hyaloid extending right from the posterior pole right up to the pars plana. Ultimately, like doctor is saying that it did not respond, there was a vitreomacular traction that was developed, And then Dr. Cyrus did a vitrectomy, and this membrane has been removed, and we have resorted this condition back. And an atrophy of the center has also developed. You can see a little bit of changes at the level of the RPE. So there is a lot of inflammation, persisting, grumbling inflammation, and you can give clindamycin along with dexamethasone to your patient intravitreally till the inflammation subsides. Dr. Payman has done the first work on this, and he feels that 2 to 3 injections are what is required to kill the inflammation. I still feel that your case has got inflammation and there is still yellowness. It is not pigmented. Once the toxoplasma lesion heals, it will become pigmented. So I would give maybe intravitreal injection of clindamycin till it becomes fibrosed and heals. And if then there is VMT, then we can go ahead and do a vitrectomy. And if the macula is not distorted, then we can avoid that.
Risha,
please.
Risha, Dalacin C, clindamycin, dose is 300 milligram 4 times daily.
Sir, since it's a 15-year-old girl with 45 kg weight, so I thought QID, will it be too much, sir?
No, it's okay. Sometimes I give 7 or 8 years
between
old, I give
40 and
half.
45 kg.
Yeah.
Mm.
Manisha,
Already,
yes.
Manisha, please.
So, yeah, thank you, sir. So, Risha, very interesting case. And I think this is the usual picture we often face when the patients of toxo are being managed. So, as you rightly mentioned, that this patient apparently had got IVMP initially and then was put on oral steroids without any specific anti-toxo treatment initially. So probably the kind of response that we were expecting when you started the patient on Bactrim DS, you probably did not get it because it had already been aggravated by giving the steroids without being under the cover of anti-toxo treatment. So I think initially that is why you were a little surprised and a little worried that why the patient is not responding. And as Dr. Shishir mentioned, I think in these cases, we have to be very aggressive initially in treating these patients. So like it's a zone 1 disease. So here you have to use all kinds of modalities of treatment, right from intravitreal as well as the systemic treatment. And you have to continue the treatment for a little longer time till you're absolutely sure that the infection and the inflammation are both under very good control. Because what gradually happens, as is beautifully shown by Dr. Shishir's cases, that the posterior hyaloid, it just keeps getting inflamed and ultimately starts causing a traction. Like in your case also, the traction is starting to develop on the macula, though the patient is lucky that he's still continuing to maintain a very good vision. But I would surely agree with Dr. Shishir on this point that it is not the end of the story. You still have to continue your anti-toxo and anti-inflammatory treatment. And finally, if the patient starts developing an active traction with drop of vision, probably you'll have to resort to a surgical intervention.
So when to intervene, madam, surgically, which is the ideal, when to, ideally when to?
So surgically would be first, I think the foremost would be to control the inflammation and infection, keep the patient under a very good regular follow-up. And only when you will start seeing an active traction developing on the macular area with the drop of vision, I think that would be the time to surgically intervene in this patient, not before the inflammation is under control.
And how common is BRAO along with the toxo?
You see, the retinal blood vessels, the inflammation is in the inner retinal layers, and the blood vessels are running in this layer. So vascular occlusions because of inflammation from without is reasonably, I won't say common, but they are not rare with toxoplasma. I and Dr. JB are sharing one patient of very severe toxoplasmic retinochoroiditis, which has developed neovascularization and fractional retinal detachment, and is started to bleed also. And one will have to do a VR surgery just for the neovascularization. Even in your case, maybe the CNP areas are extensive, and one may have to do a sector laser treatment after the inflammation gets controlled. So BRAO and BRVO partial are not very rare, though not common. And the reason is because it is the inflammation within the retinal layers.
I had a case of vitreous hemorrhage due to the toxoplasma. Sure. When vitrectomy was done, the toxo lesion was found to be healed. And we could see the classic toxo lesions in there. And branch retinal artery or vein occlusion has been reported in toxoplasma. I will show you some slides for that at the end.
Excuse me, ma'am, Manisha ma'am and Shishir sir. LG sir had a question that when would you start with intravitreal antibiotics upfront along with the systemic anti-toxo treatment? In what cases would you prefer to go ahead with an intravitreal straight away?
I think if we have a zone 1 disease and it is involving the macular area and it's vision threatening, I think in today's time we all upfront start using intravitreal combination of clindamycin and dexa along with the systemic anti-toxo treatment.
I give in pregnant people, pregnant women. Pregnant woman is one of the indications.
Yes.
And then zone 1 is not recommended, but I try with the oral treatment with dalacin C, azithromycin or Bactrim DS.
But you are
actually, sir, in pregnant females, actually, sir, we have actually done a case study where we avoided giving any kind of systemic treatment. And the patient responded very well just to intravitreal clindamycin and deca. And we had also done a sampling from the fetus. And apparently there was absolutely no evidence that we could find of a congenital toxo also. So I think it is still controversial, but I think more and more now we have started opting just for an intravitreal treatment in pregnant females.
In pregnant ladies, if you have to give systemic, spiromycin is the drug of choice rather than clindamycin systemically.
Yeah, sure. Suchitra has got any point?
Sir, I prefer to treat this case with azithromycin also because it is in zone 1. Only Sepmax will not be sufficient, we feel. In SNB practice, 3 weeks azithromycin and followed by for continuation, once the lesion starts resolving, we add on Bactrim also. And the treatment has to be continued till we make sure that the lesion has started healing and totally scarred. Till then, antibiotics will be required with cover of steroids depending on the inflammation in the vitreous. And intravitreal we have given, but not on a primary treatment. We do still want to give systemic treatment. And then if it is not really responding, you want augmentation, probably intravitreal we give.
There is a question in the chat box. Among the options for systemic treatment, which one is preferred as first line and why? When the disease is very close to the fovea, then I would like to give clindamycin because it's more effective, and you can combine clindamycin as well as Bactrim. And if it is outside in zone 2 or 3, then I am not in a rush to give clindamycin. I can give Bactrim. But once I've given clindamycin for 2 weeks to 4 weeks, then I would shift the patient from clindamycin to Bactrim DS. JB, what do you do?
I give clindamycin first as a first choice and combine with azithromycin. But I have seen one case developed an epimacular membrane. So then it was not responding to the clindamycin. So I wrote to Dr. Narsingh Rao. He said, give a standard treatment, pyrimethamine. So we gave the pyrimethamine that patient, that epiretinal membrane spontaneously got detached and disappeared slowly. So we reported that case, the spontaneous separation of epiretinal membrane, epimacular membrane following pyrimethamine therapy. So sometimes we might have to give pyrimethamine, which is the age-old drug for toxoplasma.
And most of the patients, when we give clindamycin, in our practice, we have seen they develop pseudomembranous colitis, most of them. So azithral is better tolerated than clindamycin in these cases. I believe in azithral and Bactrim.
And at any stage with systemic treatment, you can combine the intraocular treatment.
Yes.
Yes, when it is not really responding as per the norm, then we add intravitreal clindamycin also, but very rarely, not on a regular basis.
So in Dr. Risha's case, which has been presented, would you give intravitreal clindamycin at this stage? There is still activity and there is an epiretinal membrane which is reaching the center of fixation.
Yeah, see, in Risha's case, actually, they have given only Bactrim DS. They haven't given azithromycin or clindamycin, and it was treated with steroids before they started on the antibiotics. And I think we should add one more oral antibiotic, and of course, we can give intravitreal also because it is not really responding to treatment, and the whole picture has been changed because of the IVMP given before.
Dr. Risha, I think Dr. Rupesh wanted to see the images again.
Yes.
Could you please share the images once?
Yes, sure.
Just wanted to see whether it is a real PRA or can it be carried as flex. So this is the retinitis lesion. So just increase the, so this is definitely the retinitis lesion, what we see retinochoroiditis. And when you see the caryless flex, so those are adjacent to the retinitis lesion. So probably Dr. Pichi has described the maximum number of cases. Otherwise, those are very little, but it's been underreported. So go to, fundus photo, then maybe open the OCT. Is it passing through that?
Yes,
and
this was
ICT can
the
be.
initial.
So Rupesh, actually there are extensive CNP areas also that you can see in the infratemporal
This
quadrant
was
on
the
FFA.
Yeah, but still, Manisha, I'm just trying to rule out because on ICG, the vessel will stay nicely and it will stand up quite significantly, and it will be adjacent to it. So just trying to see through whether it can be caryless flex.
There's all a blockage.
Because there are
of
the areas of CNP, definitely.
There's no
Yes,
vascular flow. There's no vascular flow that you can see in the arterioles.
Sure. Absolutely. So there is this definite PRA, but otherwise I was just thinking whether there is a caryless flex like arthritis kind of thing.
So we'll summarize now. We'll move to the next case. I think this is a very interesting case. The role of intravitreal clindamycin has to be kept in mind. And there is a very rare occurrence of branch retinal artery occlusion. And this is a very challenging case. We'll move to the next case. Because
yes, sir. 1 second, sir. So is my slide visible, sir?
Yeah, Dr. Eliza, just go down.
Yes, sir. Yes. Is it there, sir, on the screen?
Yeah,
I'm unable to see my screen for some reason. So I would like to welcome Dr. Eliza for the next case presentation. She's an ex-medical retina and uvea fellow from SN Chennai and is currently practicing uvea at Arvind Eye Hospitals in Chennai. Dr. Eliza, I would like to hand over the presentation now to you.
Eliza, please.
Dr. Eliza, are you on? So I think maybe we can ask Dr. Mauli to present first and then we can ask Eliza. Okay, she's there.
Yeah. Yeah, Eliza, we can see your slide. Please go ahead.
Okay, good evening, everyone. So I'm presenting a case of atypical post-fever retinitis. So this is a 27-year-old male patient who presented with right eye blurring of vision in 7 days. He had history of fever 1 month ago. He was tested COVID negative, and it was a fever of unspecified origin. There was no specific diagnosis. His best corrected visual acuity in the right eye was 6/60, left eye was 6/6. Anterior segment was normal. Anterior vitreous phase had 1+ cells. So this is his fundus picture. Right eye had a mild wit haze, and there were retinitis patches, cotton wool spots, retinal hemorrhages, arthritis, phlebitis. Then at the macula, there were hard exudates, macular edema, and there was this streak of subretinal hemorrhage here. And left eye also had fluffy retinitis patches along the inferotemporal arcade. So at the first visit, his OCT at the macula showed a subretinal fluid with macular edema, and along the retinitis patches, there was this hyperreflectivity with thickening of the inner retina, and there was no back shadowing of the retinitis, and the underlying choroid was also not thickened. Left eye OCT through the macula was dry, and through the lesion was similar to how it was in the right eye. Coming to the investigation, the uvea workup was absolutely normal except for the peripheral smear, which showed reactive lymphocytes. So here our provisional diagnosis was post-fever retinitis, probably viral. And considering viral, we started the patient on oral valacyclovir 1000 mg TDS with topical NSAID drops. So at this second visit, we did the FFA here. So we can see there was early hypo at the areas of retinitis, both hypocynescence and hypofluorescence. In the late stages, there was fuzzy hypofluorescence with vasculitis. And here again, there is hypocynescence here. Left eye also similar picture of late hyperfluorescence at the retinitis with vasculitis. So this is what we noted. After 2 days when the patient came, we again repeated the OCT, and just with the oral antiviral treatment, there was a significant reduction in the subretinal fluid, although the vision was same. So at this stage, we added oral steroids, low dose, 0.5 mg per kg per day, and we continued the oral antivirals. So after 1 week, when the patient came, his serum IgG was positive for VCV and HSV1. So here the vision was 624 and SRF has reduced significantly. So though the macula was becoming dry, but the retinitis lesion was still persisting. So we gave a ganciclovir injection intravitreally here. And we can see here, he received 3 intravitreal injections in the right eye. And after the 3rd injection, there was almost complete reduction of the subretinal fluid and complete visual recovery, although the quality of vision in the right eye was not good, but both eye vision was 6/6. And you can see here the retinitis had completely resolved with few hard exudates here. And left eye also, there was complete resolution of the retinitis patches. So this case, our final diagnosis was post-fever retinitis, which was probably viral in etiology. So my points for discussion I want to put is any past experience of these post-fever retinitis of viral etiology, and that also non-necrotizing herpetic retinopathy, where there is no full thickness necrosis as it happens in viral retinitis. And is intravenous acyclovir preferred over oral valacyclovir? And any experience with intravenous ganciclovir used for post-fever retinitis? And what could be the OCT, a word about OCT features to differentiate viral retinitis and toxoretinitis? Then what could be the mechanism of subretinal hemorrhage in viral retinitis? Like we have seen in some of the CMV retinitis SRH, but here we had subretinal hemorrhage also. And also a word about role of anti-VEGFs in treating macular edema associated with post-fever retinitis. And if this was not viral, what could be the choice of normally the choice of antibiotic in post-fever retinitis? Like other than doxy, is there any other thing? And when will we put steroids in post-fever retinitis after giving a course of? Is it like 2 days, like how we do in toxo, or after 4 to 5 days? Thank you. So the case is open for discussion.
Manisha will take over. First, Manisha, let's Manisha.
So thank you, Eliza. Again, it's a very interesting case.
Stop sharing.
And
Liza, stop sharing.
I think there's a very interesting article and a lot of work done by Dr. Padma from Narayan Netralaya on this particular topic and entity. I actually had a few questions in my mind that when you opted for the systemic antiviral and also opted for ganciclovir intravitreal injections, what made you actually feel that it was just a post-viral retinitis that you were dealing with? Because if you see the investigations which were done when you decided to treat the patient with antivirals, I really didn't see any workup being done to find out what was the etiology of this.
Yes. One thing is we did the basic workup, the MAN2, TPHA, all was done. But clinically, the findings that I want, first there was a history of illness, which could be a viral fever. Then peripheral smear, which showed reactive lymphocytes, which are again seen in a viral illness. Then clinically, what we found was the presence of arteritis and phlebitis both. So again, arteritis is more common both in toxo as well as virus. Subretinal hemorrhage was another finding, which we again commonly see in viral retinitis. So considering all these things, we thought of, and there was like almost like a small BRVO with the macular edema there. So we thought this is more of, because in toxoretinitis, we don't see hemorrhages. It's always a retinitis patch with macular edema. Very rarely we see speck of retinal, intraretinal hemorrhage. But in this retinitis, we had adjacent intraretinal hemorrhages and subretinal hemorrhage. So we suspected more of a viral thing. And that is why we gave that oral antiviral. So when the patient normally comes with MAN2 and all the reports after 2 days, so we objectively demonstrated that with the oral treatment only, there was a reduction in SRF, just the oral antivirals, no steroids.
So actually, if I was to see the clinical picture of your patient, I would not really think of a toxo in this particular patient. Yeah. I would surely think of a post-fever retinitis. But as far as the post-fever retinitis is concerned, again, you can have several causes which can cause a post-fever retinitis, varying right from a typhoid or a dengue, chikungunya, or a post-viral, as probably in your case. Now, if we just see the cases which have already been reported in literature, I really don't think that in these cases, it's more of like an immunological reaction and the deposition of these, antibody antigen complexes, which is taking place. And subsequent to that, you are having all these, signs which are developing right from cotton wool spots to hemorrhages because of the vascular occlusions. You're having macular edema, you're having serous retinal detachment, and also optic nerve involvement. So I personally feel that in this, I think it was an overkill for treating the patient with antiviral and with intravitreal ganciclovir. I probably would have just opted for, if I felt that the patient was, like your patient had a 660 vision, probably I would have just given a course of oral steroids and seen how this patient would have responded. And in a few cases of mine, I have given an anti-VEGF. That is another thing which these patients have responded very well. As far as the subretinal hemorrhage is concerned, these patients sometimes can develop a very small underlying CNVM. So probably you could have opted for something like an Octa, though your FFA doesn't really show any evidence of CNVM right now. But that is very suspicious where you have this evidence of a subretinal hemorrhage. So these are a few of my observations in this case. I would be happy to listen to other panelists.
Please, Dr. LG.
No, that subretinal hemorrhage is just a non-specific sign.
Yes.
That it is not necessarily caused by a virus. It just reflects only vascular damage. And the vascular damage can occur due to any inflammation, any infection, and that produces a bleeding intraretinally or subretinally, depending upon which part of the vessel is ruptured or damaged. I don't think we can give too much weightage to the subretinal hemorrhage as indicative of a viral nature of inflammation. It's just non-specific sign.
You can see in toxo also.
And actually, this is one of the cases from 3 series, which we have already sending for publication. Actually, there were 3 patients who came within a span of 1 month. One case patient had typhoid, one patient had UTI, and the third patient had this a non-specific fever. And actually, we wanted to give steroids, but when the patient came at the first visit, it was a posterior pole lesion. We cannot start steroid upfront because blood tests were not ready. So we had 2 days time to see the MAN2 and all the reports. So that is the reason, because if it was viral, we wanted to give oral valacyclovir, just see the response, because if it is post-fever retinitis, it will go only with steroids. It should not go away with antivirals. So because it responded, you could see that OCT, which I showed, there was a significant reduction in SRF just with oral valacyclovir. So that is again what prompted us that it could be a viral. Otherwise, without steroid, how could the result? And why we gave ganciclovir is, in spite of 1 week of steroids, the SRF went off, but the retinitis patches were not resolving at all. So that is why vision was 625. The moment we gave ganciclovir intravitreal, that's when the retinitis patches started actually resolving. So that's why, and it was posterior.
Dr. Eliza, the dose of steroids you started was it's quite low, only 0.5 mg per kg.
Yes,
normally, if you want that grade of macular edema to settle down, 1 to 1.5 mg per kg would have probably been a more suited dose. So maybe that is also one of the reasons why your macular edema did not come down as fast as you would have liked it to.
No, macular edema came down very fast. That's what I'm saying.
That is because you added. That is because you think that you added the IV antiviral as well, the intravitreal antiviral.
Viral.
You added that based on that thinking, right?
No, not based on that thinking. You see, the SRF had gone completely within a week with steroids, but the superotemporal arcade, the retinitis lesions were not resolving. There were two foci. One was the macular edema, which was going very well with steroids. So patient vision became 624. You see the OCT, it's almost dry by 1 week because of steroids, just with 40 mg. But the retinitis lesions superiorly were not going. So only for that we gave and it was a posterior pole lesion, so we gave ganciclovir. And with one ganciclovir, there was a very good response. These were the superior lesions that we were aiming to reduce with the intravitreal, not the macular edema, not at all.
Dr. Elisa,
got any point? Suchitra, can you?
Dr. Elisa, 1 week is a very short time for retinitis to resolve with whatever treatment you give. It takes time for the retinitis to resolve. And if it can be still non-necrotizing herpetic retinitis or unlikely to be other reasons of post-fever retinitis. But 1 week is too short a time for us to comment that retinitis is not resolving and giving intravitreal ganciclovir. And most of these cases, as we have seen in SN, by their natural course only they will resolve and vision will come back to normal. But you are justified in giving steroids and antivirals because the vision was less in the right eye. But 1 week is too short a time, I feel, to tell that retinitis is not resolving. We need to give time. Usually at least a month time we need to give to see whether retinitis is resolving or not, and you have started on antivirals also. If it is non-herpetic, maybe the valacyclovir will not help.
How many of us would really opt for intravitreal?
Shishir, you can have.
I will go.
I think no, I will not go for intravitreal in this case, because you see, you are already calling it post-viral retinitis.
Yeah.
So the viral is already over. You are getting an immunological reaction here. Even COVID has told us that the infective period is only 14 days and then it's all the immunological story. So here, when the fever was a month back, the viremia was a month back. So now we are dealing with the hypersensitivity situation. And probably if you would have held on for another week, the retinitis patches would have become lighter. They will take at least 6 weeks or 8 weeks to become light. I would not go intravitreally unless I was seeing a fulminant vitritis or an infection there, which is not there. There's more of an immunological reaction, as Manisha had said. So I think Padma Malini has shown a series of patients only treated with steroids, not given any antiviral treatment. So you can just give oral steroids and that will do the trick.
And one more this thing I have questioned. If this was why was there good response to oral antivirals for the first 2 days when the patient came?
It might have been a spontaneous resolution anyway.
It could also be the natural course of the disease also.
Yeah.
I think naturally also it would start regressing in a few days.
Let's put it the other way around. If it was infective, would it have caused resolution of fluid within 3 days? I doubt it. You've got acute retinal necrosis and then it doesn't go away. it just keeps on worsening, then the immunological reaction will set in. If this was infective, then it would have taken much longer for the antivirals to act. What do you say, Dr. JB, to that?
I summarize the case. I think a workup should be to do all the rickettsia, typhoid, chikungunya, everything along with the virus. And serology is of less importance. Is really not based on the serology because it's a ubiquitous herpes simplex, herpes zoster, cytomegalovirus. These are ubiquitous. Serology is not much useful.
Actually, he was already worked up for his fever because it was non-specified. So the physician has already tested for UTI, salmonella, typhi. All those tests were done by 1 month back when he had fever. So all those were negative, and that's why they told it was a non-specific fever. And they did COVID also. So everything came negative.
So option of this case is the treating with the steroid or no treatment or giving oral valcyclovir tablet. I was a little hesitant to give intravitreal ganciclovir, though in ARN case we give intravitreal ganciclovir. So with this, we'll move to the next.
Yes. So we would like to move on to the next case because of time constraints. Thank you, Dr. Eliza.
Thank you.
Hello, JB.
Hi.
Hi, JB. Hi.
Nice to see you.
Nice to see you all.
Yeah, last case is going to be presented by Molly.
Sure. No problem.
So welcome, sir. Now I would like to invite Dr. Mauli Shah. She's currently pursuing her fellowship in Uvea and Medical Retina from SN. And I would like her to present her case now, please.
Yes. Good evening all. Are my slides visible?
Yes, Molly, we can see.
Okay. So today I'll be presenting a case of 23-year-old male presented with complaint of floaters in both the eyes for 6 months. So his past history and investigations were his MON2 was positive and also quantiferon TB gold was positive. His HRCT chest shows necrotic lymph nodes and pneumonitis, suggestive of Cox etiology. He had also history of contact with TB patients, and he was already started with the treatment modified ATT and oral steroids, and he has undergone 2 PRP laser sittings in both the eyes. So he was given modified ATT because he developed toxicity to isoniazid, liver toxicity. So he was put on modified ATT. This was his first presentation. This photograph was sent by local ophthalmologist. His right eye showed periphlebitis with multiple hemorrhages, and left eye he was presented with vitreous hemorrhage. So when he presented here in our department, his best corrected visual acuity in both the eyes were 6/6 with normal IOP, and anterior segment was normal in both the eyes. We did optos. His right eye opto showed multiple PRP laser marks, and left eye showed fresh vitreous hemorrhage. We did FFA, and it showed multiple areas of leakage. So we decided to treat with fill-in PRP for both the eyes, and as he was having liver toxicity because of ATT, we decided to treat with the sparing systemic immunosuppressant. So we gave intravitreal Ozurdex for the left eye. But after 15 days, patient again presented with sudden diminution of vision in right eye since 1 week. So his vision dropped from 6/6 to counting figure close to face in right eye. And his IOP were normal in both the eyes. And on examination, right eye showed vitreous hemorrhage. So this is the fundus photographs of right eye showing vitreous hemorrhage, and left eye, it was also showing some resolving vitreous hemorrhage. So we decided to treat with anti-VEGF, and we gave ranibizumab intravitreal in right eye. On next follow-up is both the eye showed resolving vitreous hemorrhage. But on FFA, we found out neovascularization elsewhere and neovascularization of the disc. So we decided to just observed. But on next visit, we found out that this neovascularization was still persisting, and we decided to go for anti-VEGF in left eye. And he again developed vitreous hemorrhage in both the eyes. So in right eye, second dose of injection ranibizumab was given. To summarize, he was given intravitreal ranibizumab in right eye, total 5 doses every month for consecutive 5 months, and second dose of anti-VEGF in left eye after 8 months. After last anti-VEGF injection, his best corrected visual acuity in both the eyes were 6 by 7.5 and 6x. And all fundus was stable. But FFA showed persistent neovascularization. So we did fill in PRP for the left eye. And SSOCT was also done for both the eyes, but there was no signs of seeing. After 4 months, when he again came for the follow-up, both the eye fundus was stable. And FFA showing no activity. So we decided to wait and watch. But in August, he again developed vitreous hemorrhage in right eye. His best corrected visual acuity of both the eyes was stable. It was still 6.6 in both eyes, but he was advised right eye vitrectomy with endolaser and tamponade. And we planned to send the vitreous sample for RT-PCR to rule out MTB. So to summarize the case, this patient presented with occlusive vascularitis of both the eyes, and on investigations, his QTB Monto was positive, and HRCT chest was also showing Cox pathology. So he was started with ATT and oral steroids, but he developed neovascularization, NVE and NVD with vitreous hemorrhage for 5 times in both the eyes within 8 months. So we treated him with laser plus Ozurdex in left eye with anti-VEGF in right eye for 5 times and left eye for 2 times in 1 year span. But he continued to have recurrent vitreous hemorrhage, and last week we performed vitrectomy for the right eye, and the sample was sent for RT-PCR for MTB. So the queries that remains are: ATT has been shown to reduce recurrence of inflammation, but occlusive tubercular vasculitis with recurrent vitreous hemorrhage after complete course of ATT. How to handle such scenario? We should do FFA or monitor clinically. Anti-VEGF, how frequently we can give anti-VEGF to this in such scenario? Vitrectomy, any role in deburking the inflammatory load or stimulus? And if vitreous specimen comes positive for MTB, role of ATT again? Thank you.
This is my case, actually. I saw this patient. If Dr. LG was here, I would have taken his opinion. I would have shown the case. But he is here now. I just like to ask him his opinion, what to do in this case. Dr. Gopal, please.
The first point I'd like to make is that why was Ozurdex given if it is? Because
he was a hepatotoxic, his liver function was pretty abnormal. So we couldn't give the immunosuppressive treatment or oral steroid. It was not. So he developed a lot of complications due to the oral steroid. So we give him the Ozurdex injection.
There was active inflammation in the eye when you were treating him, right?
Yes.
Is that the reason why you wanted to give Ozurdex? Because usually at a stage when there is a lot of frank neovascularization and PRP is done in a case of perivascularitis, which we used to call as Eales disease in the past, you will get the inflammation is almost gone at that stage.
Yes.
For a vascular occlusion and the sequelae that we are dealing with. At that stage, it behaves more like a proliferative vascular retinopathy rather than an inflammatory disease. So, although there are a few patients who can get inflammation as well. So the role of anti-VEGF in proliferative vascular retinopathy, the argument for and against is exactly similar to what we do for proliferative diabetic retinopathy, where not everybody agrees that we should treat them with the anti-VEGFs. But yes, it has been shown to be useful, except that recurrences are very common once you stop the anti-VEGF, like in this case. Now, when whether you depend your continuation of treatment on angiogram, I don't know. Frankly, I would say, repeating, if we do angiogram, even a fibrous tissue will stain. That doesn't mean there is active florid vascularization. I would go more by clinical judgment. If there is florid neovascularization, perhaps I'm justified in giving anti-VEGF. But what we should understand also is that there are mechanical reasons why bleeding occurs, which is hemorrhage, not necessarily because the neovascularization is florid. Because when the vitreous is detaching, it tugs on the new vessels and they start bleeding. Even a vessel which is partially regressed can bleed. And in such cases, you have to do vitrectomy. And then also along with it, you to give some additional laser. So I wouldn't think that anti-VEGF repeatedly being given is the treatment of choice. Yes, if it's not responding, if he bleeds, go ahead and operate. And along with surgery, we give anti-VEGF. That would be my.
So it was having almost like periodic bleeding, about 6-7 times bleeding. So I took opinion from Dr. Amod Gupta. He said, why don't we give the anti-VEGF injection monthly? So I took the decision of giving that one. I was really at a loss. You are not here. So
I'm not, nothing against anti-VEGF. I'm only trying to say, put it in the correct perspective that recurrent vitreous hemorrhage does not always mean florid new vessels. And anti-VEGF doesn't always stop the bleeding from occurring because the bleeding occurs mostly due to vitreoretinal anatomy being disturbed. There is partial PVD, it need not be full PVD, and that can tug on the vessels which are partially involuted but are still patent, and then they start bleeding intermittently. So those cases are best dealt with by combination. You remove the vitreous traction and also give anti-VEGF rather than only anti-VEGF. But yes, there is a different role of anti-VEGF itself, no doubt about it.
Anybody else has got any comment?
Not after LG, sir.
Okay. So is that Rupesh, you have got any comment?
Sir, just a couple of comments about the anti-tubercular therapy as Dr. Modi has asked in his slide. I think Dr. LG is very well covered about the anti-VEGF and all the retina part. About the retinal vasculitis, as such, the anti-tubercular therapy is given whether it is 6 months, 9 months. So when it does not respond, that does not mean that the patient never had a TB. There can be many reasons. Typically there can be 4 reasons. So it was never a TB to start with. B, probably a TB resistance. C, the patient never took proper treatment. And 4th, it was just probably a bit late and probably the inflammation was a bit more, so that you can never got on top of it. So there are 4 different reasons why a patient with tubercular retinal vasculitis might not respond. So when you treated a patient completely 9 months or 12 months or something, and you are on the steroid, after that probably the role, and if you see the active inflammation, which will be visible on the FA, then your role will be mainly to give steroids and probably some immunosuppressive agent if there is active inflammation which is going on. And if after doing vitrectomy, and if the TB PCR comes positive, which happened to come positive in one of my own cousins who had this intermediate uveitis, we did a PCR vitrectomy. Pramod Binde sir did it, and his PCR was positive, but we never treated. It's 8 years now. He's never got a recurrence of intermediate uveitis since then. And does not mean that you get a TB PCR positive. That means you have to treat it. You can leave it unless there is active inflammation. Then only you treat it, but you don't treat TB PCR as such if it's positive. Okay, thank you.
Okay, we'll summarize today's one. I just have done a little homework. I'll show you some discussion slides. Can you see my slide?
Yes, sir.
Yes, JB.
Yeah. Just last few points is that one. This is a patient of retinitis with hemorrhage. And this patient was little diagnostic dilemma because it came with that without any history of fever. But this patient, when we looked in the patient as a whole, we found the vesicles over the forehead. Based on that, without doing any PCR, we treated the patients with intravenous acyclovir injection, and you can see that there is a significant resolution of lesions. And this is a varicella zoster virus retinitis. So post-fever retinitis or any kind of necrotizing retinitis, viral fever has to be looked into. And also the chikungunya rickettsia, typhoid, dengue. These are all the features can produce as a kind of a post-fever retinitis. And this was we published in American Journal of Ophthalmology case report, atypical post-apol retinitis, just like what Elisa has presented. And this is a chikungunya actually, history of fever 3 months back. We did the PCR. PCR showed chikungunya RT-PCR virus, chikungunya virus was positive. And patient responded with the without any treatment with the steroid only. Chikungunya is RNA virus, so we treated the steroid, it resolved. So Eliza's case, it might have resolved with the steroid only. And then regarding the Risha, that there is a report of retinal vascular involvement in acute toxoplasmic retinochoroiditis. There are about several cases has been there. And here is one of the examples similar to Risha's case. There is a retinal vascular occlusion. And this is first reported by Donald Gass branch retinal artery occlusion caused by the acute toxoplasmosis. So it's rare, but it's not that it has never occurred. And regarding the East disease, we studied about 500 patients and 900 eyes, 898 eyes, and we found that the 52% of the patients had 5 recurrences over 10 years period, neovascularization. But our case is within a span of a year, it developed neovascularization several times and vitreous hemorrhage. I didn't know that what to do. I get that idea from Dr. LG that we probably is justified in doing a vitrectomy in this case. So with this, and then there is we did a study of the vitreous specimen from the East disease patient, and we found that there is a strong expression of vascular endothelial growth factor in the East disease vitreous specimen and weak expression of pigment epithelial derived factor. So I'll stop sharing. We have time for oration. I'll request Dr. We like to thank all the speakers and panelists for the Uvea capsule for a wonderful presentation and discussion. And particularly, I thank Dr. LG for giving us the last word about each case. And it's really nice, fortunate for us to have him here with this Uvea capsule. Now I request Dr. Mohan Rajan to take over the most important part of this today's program, SN Alumni Oration.
Okay, thank you, JB, and good evening all the delegates here and all the SN alumni members and who are gathered in large numbers on the YouTube and the Facebook as well. As you know, the Shankar Netra Alumni is the most vibrant alumni association you can ever see. And you can, we are having regular webinars on every subspecialty of ophthalmology. And even 2 months back, we are on glaucoma and refractive. Today, we are having on Uvea and Retina. And we have the prestigious SN Alumni Oration. I'll just share the screen just to show you what exactly is this SN Alumni Oration. And able to see my screen?
Yeah. Yes.
Friends, we have the blessings of our Guru, Dr. SSB and Madam Vasanti Badrinath Madam. Always, I spoke to them, spoke to Chief and Madam a couple of days back, and they're all keeping good health. And they blessed us and wished us all success in all the webinars. And as you know, Shankar Netra Alumni is celebrating 33 years of its existence. And one of the earliest founders is right here. Dr. T.S. Surendran is right here, who is the vice chairman of Shankar Netralia. We have Dr. Natarajan as the president, Dr. Mohan Rajan, myself as the secretary. And of course, the main, I would say, the nucleus of the SN alumni is none other than Dr. JB, who has been the main fulcrum, I would say, as well as the scientific content of the webinars, as well as the physical meetings are concerned. Thank you, JB, for being the, being instrumental in getting all the top-class scientific content for us. Today, we've got a very interesting webinar. The Uvea capsule is just over, interesting discussions, and we're going to have the SN Alumni Oration now, and followed by the Retina capsule also. And we started this SN Alumni Oration way back in 2015, and the first oration was given by Dr. Surendra Basti, who himself is an alumnus of Shankar Netralia and who's doing so well in Chicago now. Then followed by Deepak Edwards, also from the USA, Anita Agarwal, who's a retina surgeon from USA, and Amod Gupta, who's a top retina and uveitis guy from Chandigarh, and G.N. Rao. Of course, everybody knows all these people were all people in 2019. In 2020, we were not able to do the oration, and we have none other than Dr. Nam Perumal Swami. To introduce Dr. Nam Perumal Swami, it would be actually an insult to introduce him, but everybody knows about Dr. Nam. He's I would say the gold standard as far as the ophthalmology in this part of the world is concerned, and the chairman emeritus of the Arvind Eye Care System. And the citation will be read by me very soon after the felicitations, and this is the plaque. And thank you very much. I'll stop sharing the screen. Over to Dr. TSS, our guru, mentor for the Alumni Association. He's been the main pillar, I would say, as far as the Alumni Association is concerned, right from the beginning. And sir is, as you know, the vice chairman of Shankar Nethralaya, and he will felicitate Dr. Nam Perumal Swami. And then following that, I will read the citation of Dr. Nam Perumal Swami. And I think we have already given the citation and the plaque to Dr. Nam by courier, and he will be showing it during the oration. Sir, over to you, sir, Dr. TSS.
Yes, sir.
Please unmute yourself, sir.
Am I audible now?
Yes, sir.
So our salutations to our mentor, Dr. Badrinath, and I congratulate all the organizers as usual, Dr. JB, Dr. Mohan Rajan, and Dr. Nati. And Mohan, I think it is the 35th year now, because 89 we started at Ahmedabad, Shrinex Shah's house with 15 members. So now it is 35 years. 30 years, I think we celebrated in Taj, if I remember correct.
Yes. 30 years in Taj, sir. 25th year is Silver Jubilee in GRT, Radisson.
GRT, Radisson, correct.
Yes, sir. 34 years over, sir.
34 years over, correct. So I think Nethralaya side, I thank many corporates like Tata Trust, HDFC, ICICI, and other companies for COVID care supplies. Tata's alone, this time alone, they gave 15,000 PPE kits with masks. And thank Alumni Dr. G.S. Rao for donating 1 lakh this year. I think followed by the big group of BB Foundation donating about 10 lakhs last year on my request. And so Nethralaya has been selected as the best 4 eye institutions in the whole world by Newsweek United States, and is 2nd year in a row. So congratulations to all the ophthalmologists, fellows, postgraduates who have been, I think, showing, I think wherever you see in the award section at the AOS, I think it was all SN, some either fellow or a former consultant or inside and outside. So I'm very proud of them. They continue to do that. And I would like to highlight 10 members led by Dr. Shubhaneshwari. And 10 members, I think they went to Stanley Medical Hospital and served the active COVID patients for a week continuously. They stayed there, and then I think they were on quarantine. So I think I would request all of you to applaud them. This is not a joke to enter into the den of a tiger. So our Raja Annamalipuram branch has started. And also another good news is that Lingam Gopal will be back in February. Super. He is returning to India in December, and then January he takes a break to a trip to Germany. He'll be joining Nethralaya full time from February. So look forward for Lingam Gopal. Let us go to Professor Nam. Nam's picture is not seen, Mohan.
Shall I put it, sir?
Yes.
You want me to put it?
No, if he's around, okay.
No, he's there, sir. He's
Okay.
there.
Sir is there.
Sir is there.
Good
Okay.
evening,
Thanks.
ma'am.
Good evening, sir.
Good evening, sir.
Welcome, sir.
Good evening.
Yes.
I think we should give a big round of applause. Put our hands together for Dr. Nam.
Yes.
It's my proud privilege to introduce Professor Nam Perumal Swami, who is very well known all over the world in the eye fraternity. He is one of the founding pillars of the Arvind eye care system. And he moved out from government of Rajaji Hospital and later trained in Boston and also with Payman. So there is an interesting story when he when he came back after training with Payman. I was with Dr. Badrinath in 77, 78. I think that time Dr. Badrinath was not doing vitrectomy. So when patients came from Bombay, Calcutta, etc., Dr. Badrinath used to refer them to Nam Perumal Swami for vitrectomy. And later, I think, actually he himself used to make arrangements for the travel, etc., for the patient because they come from Bombay, they don't know Madurai. So with this, the association started. Later, Dr. Badrinath brought one instrument from Payman, just hand probe alone, and then devised a gadget, called it a Sakat, and Vijaya Sakat. Vijaya Sakat was the name of the instrument, with which Badrinath started doing vitrectomy. The first patient was an Eales disease, and it was just doubtful PL, but it came back to 6.9. That is a memory that was back in 79. He is a very skillful vitreoretinal surgeon and started vitreoretinal clinic in 79 at Arvind, and has a special interest in diabetic retinopathy, and also a pleasant surprise is on low vision aids, which is also my favorite. I was practicing low vision aids for 20 years. When Morgan was there as a fellow, I was practicing low vision aids.
Yes, sir.
So he was the chairman of the large group of Arvind eye care system, and was a best teacher, mentor, philosopher, guide for everybody there in the Arvind eye care system. He is also a recipient of the highest civilian awards, Padma Shri and Padma Bhushan, and innumerable awards I don't want to mention. I think recently it is very interesting that he is into farming. So I have a video where I think he is running a tractor around his own farm, having a good retired life with grandchildren. So look forward, Nam. I think I wish, I envy you that I should become a farmer once and relax. Still on the squints going on. God bless. Thank you.
Thank you, sir. Thank you, sir.
Dr. Nam Perumal Swami is the president of the Dr. G. Venkatasamy Research Institute now, because I visited him recently, and he is also our patron for diabetic retinopathy screening, which he started in 2000, and he also worked in TRS in 1976.
Thank you, Nati.
I request Mohan to read the citation, please.
It is actually a very, very prestigious, I would say, citation, and it's a great honor to read the citation. The Shankar Netralaya Alumni Oration Award. Dr. Perumal Nam Perumal Swami, DO, MS, FA, MS, Chairman Emeritus Arvind Eye Care System, Director Research, specializes in diabetic retinopathy, and is also a retina vitreous expert. He is a trailblazer, outstanding mentor, a humanitarian with great talent, tempered with high morality. He has spearheaded the march of ophthalmological care in India and contributed greatly to the field of vitreoretinal surgery and rural telemedicine, and pioneered the first low vision aid clinic in government Erskine Hospital way back in 1967. He also systemized a course on low vision aid for ophthalmologists. He also initiated the Vitreous Surgery Center in Government Rajaji Hospital in 1975. He graduated in MBBS from Madras University in 1963, went on to do a diploma in ophthalmology there. He did his MS through the Madurai University, obtained a research in the diabetic retinopathy at the Eye and Ear Infirmary, University of Illinois, Chicago, obtained a clinical fellowship in retinal detachment and vitreous surgery, Retina Associates, Boston, Massachusetts, under Skipens. He was a clinical fellow at Massachusetts Eye and Ear Infirmary, Harvard Medical University. NAM, as he is fondly known, has trained over 85 postdoctoral fellows in vitreoretina, and generations of ophthalmology residents have benefited from his guidance and moral principles. He is a founder member of the Govel Trust that administers the Arvind Eye Hospital and Postgraduate Institute of Ophthalmology. He launched the Lions Arvind Diabetic Retinopathy in collaboration with the Lions Club International. Dr. Nam has published over 100 articles in national and international reputed ophthalmic and research journals. He is one of the forerunners of telemedicine. He initiated research studies in basic and immunological aspects in ophthalmology, including the stem cell research for ocular surface disorders and hereditary eye diseases. His numerous awards include the Padma Shri from the Government of India, Lifetime Achievement Award by the AOS, Achievement Award by the American Academy of Ophthalmology, Dr. B.C. Roy National Award as Eminent Medical Teacher, 2001 Conrad Hilton Humanitarian Prize. He is named in the Times Magazine 2010 list of 100 most influential people in the world. I think we should give a big round of applause for that. He is an international member of the American Academy of Ophthalmology, active founding member of the Skipens International Society, Boston, member Skipens International Society International Advisory Board, fellow of the National Academy of Medical Sciences, New Delhi. Shankar Nethralaya Alumni Association is privileged and honored to confer the Shankar Nethralaya Alumni Oration Award 2021 to Dr. Perumal Nam Perumal Swami on 21st August 2021. Signed by Professor J. Biswas, Chairman Scientific Committee, Professor Mohan Rajan, Secretary of the SN Alumni Association, Professor S. Natarajan, President of the SN Alumni Association. Thank you very much, sir.
Sir, hearty congratulations, Dr. Nam, sir. It's a great privilege to welcome you for giving this oration on behalf of Shankar Alumni. Big namaskaram, sir.
Please share your screen, sir.
Last slide. Can you see my slides?
Yes, sir. You can see clearly.
Yeah, thank you very much. And first of all, I thank the executive committee members of the Shankar Nethralaya Alumni Association and my friend and those of Dr. S.S. Badrinath for having nominated me and conferring this prestigious award for me. Before going into the Shankar Nethralaya alumni, talking to them, I have to talk to you about Skipens alumni, because we both are the alumni members of the Skipens alumni. We not only learned ophthalmology, but also the qualities and value which he taught us to translate this culture and values to our fellows, our alumni. And that is what why I am showing this picture. You can see. And you can see, I want to see my teacher of teachers, Dr. Charles Skipens. Charles Skipens is in Boston running the associates. This is his house. This house was donated to him for $1 by one of his patients. And you can see him, he is 90 years old and going for swimming and keeping his physique. And not only keeping it, he always teaches that you have to keep up your physique before you teach or do. And this is his wife. And along with that, he is a scientist at Pomerantz. With him, he found the first indirect binocular small pupil indirect ophthalmoscope, which revolutionized the retinal detachment surgery. And also, if you see, when you see, he did scleral buckling procedure with the implant technique. They increased the prognosis of 95% in retinal detachment surgery. And One more thing I have to say, that the striker table, the table which is used for the giant retinal tear, and that is a unique, and he's always fond of going through the innovations. Also, we learned lessons from professionalism, how to do your medical profession, how to disseminate your knowledge by teaching and training, perseverance, doing surgery for more than 7 hours, a single surgery, perfection, patience, and precision. This you have to, as youngsters, we have to learn from our mentors and the teachers, which we learned. I think Dr. Badrinath knows that how hard we have been working on. And you must have positive attitude. You can do it attitude. Fortunate to get trained under Dr. Stephens, Dr. Badrinath, returned to India. And I used to wonder, he had a courage to start a single specialty, even at 30 years or 40 years ago, to nurture this vitreoretinal specialty. But not only the ophthalmology, but also translate science with all the values learned from his mentor and translate it to the fellows. A center of excellence, Sankar Nethralaya. Alumni themselves become celebrities in this specialty, cherish their valuable training. Even today, I can see the seniors are celebrating the alumni. Scientists and scholars doing the state-of-the-art, highly qualified, recognized ophthalmologists. Why I am all saying that is, you have to translate to your fellows, because you are organizing institutions. You have developed your own institutions. So you have to pass it on, the culture and the values, what we have passed it on to the fellow. And hard work, ethical practice, adherence to the perfect values. That is the basis of that, not just an ophthalmology alone, which you have to know that. You can see the young Dr. Badrinath, along with his mentor in his Sankar Nethralaya with, I think, Manju Kulkarni, I think he said younger.
Yes.
Yes, sir.
Yeah. So he is very fond of visiting and seeing, supervising how their students are doing. And this is what mentoring, this is what supervising, and you have to do that. And we are fortunate to have Dr. Stephens to come and lay the foundation stone for AEH. After 2 years, he came for inauguration of the Aravind Hospital after my training in Boston. So that is what it is. And then he comes and visits our fellows, teachers. What I'm trying to say that not that he comes to, but disseminate the knowledge, what he has learned, what we want to say. This is what is very important. Next few minutes, I will just talk to you my experience as an ophthalmologist or a founding member of an institution, how to build an institution for the youngsters, which you are all, the alumni members are all there. Health initiative in a developing country fail not because of lack of scientific knowledge, but because of managed competence. So we identified, recognized the management is very important in running the institution, developing an institution, and that is what is very important. For example, blindness is so much, but infrastructure is very small, very, very inadequate facilities, no human resources, but still we have to move on from developing country to the developed world. You are familiar with C.K. Pragala, the management group, who has visited Sankar Nethralaya, and he has visited Aravind Hospital also. And it is just like he developed a bottom of the pyramid and apex, where apex of the pyramid tier 1, there are only very few people who can afford to pay. But the bottom of the pyramid, very poor people, they cannot pay. But middle group, 2, 3, 4, you concentrate on those people, volume-wise, earn money, support the tier 5 people, concentrate, make money from the poor people. That is what the social marketing is. Get products and services at an affordable price. This is what I am talking to the younger alumni people, younger ophthalmologists, the ophthalmologists of the country doing high volume, but not compromise the quality. You have to, and this pays the capital. This is the basis of our philosophy of Aravind Eye Hospital. Aravind Way always constantly we go for innovations, service model of large volume with high quality, business model. Business is not a bad term. Social marketing. That is what I am saying. Make the people know that there is treatment available for every disease in the eye, which they can approach. That is creating a demand so that we need at least 10-fold increase of ophthalmologists in the country to carry the treatment for to reduce the needless blindness in the country. With that, you have to have the basic eye hospitals to give the tertiary care hospitals to the state of the art, from cataract to all other specialties. But when there are people who cannot come and carry, but even when those people are not able to come, we have started village vision centers every 50,000 population with the state-of-the-art technology, and by the trained ophthalmic technicians. They see them, they send the patient, they then take all the images. Every center has got a fundus camera. 94 centers are there. This increases the volume. Training and teaching the residents, they affiliated with the universities, so that increases the resident number. Telemedicine is the state of the art. These are all the things. You cannot employ all the trained nurses because you have to pay a lot of money, and that increases the infrastructure pressure. So what we train the local girls, train them, give them government certified, and they can work with us. Not only with this, about 60% of all the consumables we still import, equipments, intraocular lenses, pharmaceuticals. Is there a way that the ophthalmologists can improve on producing local medications? And this is what it is. This is a sort of a social entrepreneurship, social marketing, but the combined social service with the deliver services professionally and with quality. This is what it is, but it should be sustainable. You cannot go for after money from somebody else's. Great volume with high quality, and always you get money from these people. Still we make money. I don't hesitate to say that. 420 crores per year, spend only 313 crores. So you can still get surplus. You can have physical expansion. This is what we have been doing, the social enterprise. But what is next for the present next generation? Only very few more minutes, I will say. See, you have to have certain latest research in India, which I am heading, as Professor Natarajan told you. We are heading research in India. You have got a very good research institute in Chennai. And you have got alumni members who have already developed institutions. They can concentrate on basic and clinical research, high potential opportunities for research, but with available resources to reduce needless blindness. Research, usually evidence-based management. We still depend upon the directions given from the Western countries. We have to have our own directions for our own diseases, for our own, you have to develop methods. You have to put a base for research, bench to bedside, to improve patient care. All these things can be done only with the present generation. But you can't depend upon only the scientists. You have to have interaction with the clinician and scientists. Clinicians have to ask questions to the scientists, either in genetics, or biomarkers, or in any treatment you have, a treatment for glaucoma, cure for glaucoma, not for control of glaucoma. And all these things, you have to ask questions to the scientists. And that is what the separate cadre, a clinician scientist cadre, which we have to develop. The present tendencies, most of our eye diseases are based on genetics, inherent retinal disorders, or retinitis pigmentosa, or glaucoma, or diabetic retinopathy, are all genetic based. That is what it is coming up. And biomarkers, proteins, and transnets. And these are the diseases which you can see here are all genetic based. And biomarkers, proteomics, there are 30,000 proteins in the body. There are changes which occur in the proteins before any the disease manifests. If you can identify change in the proteins, change the biomarkers, if you can identify a clinical lab test which can differentiate which are the diabetic patients who are likely to develop diabetic retinopathy, which are the patients who are likely to develop PDR and NPDR, by noting these biomarkers. This is what we have to encourage and ignite our younger minds to do research. And genetics, yes, translation, everything must be for the benefit of the patient. It should be transferred. It should be, you'll able to translate to the patient's benefit. Whether you can pre-symptomatic diagnosis of eye disorders, so that the glaucoma part of it, you can cure the glaucoma, not control of glaucoma. It is possible. That is what we have to do. Diabetic retinopathy, a clinical lab test to find out diabetic retinopathy. No more of all these things are essential so that you can go in for gene therapy. Gene therapy, it's not the product for anybody else outside. When they can do it, we can do it. India can also lead other in doing this gene therapy and other. A combination of all this operation research, genetic research, has found a way for diabetic retinopathy model, which you are also doing, telescreening, and also you are going to the genetic model and proteomics. All these researches are done as a combined effort in diabetic retinopathy. You are also familiar with artificial intelligence. Artificial intelligence is putting algorithms in machine learning, which along with Google, Sankar Nethralaya and Aravind, we are in the process of validation of learning. It shortens the process of diagnosis of diabetic retinopathy. But younger mind must work on that, and they have to do this research, concentrate on research, real-time validation. Sankar Nethralaya is doing it, not only in diabetic retinopathy, but also in glaucoma. Also, every disease, you must have seen in 3 days ago that artificial intelligence in diagnosis of cataract by the ordinary ophthalmic technician from Dorsa. So these are all sound big, but think about nothing, you will do nothing. Think about something and great things, you will do great things. That is what we are always thinking. Some of the organizations are also doing it, and some of the organizations which are coming out of this prestigious institution should start doing it, so that we should lead the world. We should be second to none in doing research also, not only the clinical, but also that. So say always, you have all the power within you. Don't estimate yourself that you are weak. You can do anything and everything. Believe in that. Do not believe that you are weak. Stand up, express the divinity within you. This is what I am saying for the youngsters, alumni, and other people. We have to do that. This is what we have started the only thing is you must have faith and confidence. Faith, more faith. Faith in your own possibilities. First of all, you have to have faith in your own possibilities, capabilities. Faith in the power that is at work behind the wheel. Faith in the work is to be done. This is the offered guidance we have to do. So it is possible. We can move forward. We can develop from a developing world to develop the country in ophthalmic field also, to reduce the needless blindness. And Thank you very much for the opportunity given. We have to set a goal, aim high, and set an example for the entire world. We are capable. Thank you once again.
Thank you.
Thank you very much.
Thank you. 1 minute, Nati. Yes. Thank you very much, sir. I would request you to show the citation and the plaque which you had sent by courier, sir, to you, so that everybody will have a look. And yes, sir. Thank you very much, sir. It is a great honor and privilege for the Shankarnetra alumni to have you as the awardee, as well as deliver the prestigious Shankarnetra alumni oration, sir. And it was a very inspiring and motivating address. And you opened up a new vista, and you have thrown so much of light on topics like research, genetics in ophthalmology, and telemedicine as well. And thank you very much, sir. Again, once again, sincere thanks to you. Despite this, difficult times of COVID pandemic, you were able to join us virtually for this. I request our dynamic president of the Shankarnetra alumni, Dr. S. Natarajan, to propose the vote of thanks.
Thank you, sir. And I think we are all dumbstruck by your oration. So, respected Dr. Nam, sir, you have saved many from blindness and improved innumerable lives. The metamorph of dwarfs standing on the shoulders of giants, nanos, gigantum, humerus, incidentus, express the meaning of discovering truth by building on previous discoveries. And whatever you have done, Dr. Badrinath has done. The concept have been traced to the 12th century, attributed to Bernard of Chartres. However, its most familiar expression in English is credited to Sir Isaac Newton in 1676. If we have seen further, it is by standing on the shoulder of giants like you, sir. And hopefully, we are only at the very beginning of a long journey to stamp out all human suffering due to blindness. Dr. G.V. started it, Dr. Badrinath started it. With this in mind, each of us, honored to be a part of Shankarnetra alumni, welcomes those who follow to stand on our shoulders, like yours also. We know we'll have been successful if future generation brings so many new cures that our specialty will look back on us as the task. Wish all the youngsters at Shankarnetra alumni and Arvind alumni for a bright future to find cure for blindness. I also want to quote Dennis Waitley, who's an American motivational speaker, and why not we Indians can do it. The unchangeable, accept the unchangeable, and remove yourself from the unacceptable. These are two primary choices in life: to accept conditions as they exist or accept the responsibility for changing them. And I think you in Arvind Hospital and Dr. Badrinath and Shankarnetra have done that. The greatest gifts you can give your children that you have given the fellows are the roots of responsibility and the wings of independence. Don't dwell on what went wrong. Instead, focus on what to do next. Spend your energies on moving forward toward finding the answer. They expect the best, plan for the worst, and prepare to be surprised. Happiness cannot be traveled to, owned, earned, owned, or consumed. Happiness is a spiritual experience which you highlighted how Dr. G.V. has done it, and and through Dr. Badrinath, through Shankaracharya, the spiritual experience of living every minute with love, grace, and gratitude. A smile in the light in your window that tells others that there is caring, sharing person inside. Time and health are two precious assets that you showed how Dr. Stevens was doing, that we don't recognize and appreciate until they have been depleted. So, the friends, wake up. You must welcome change as the rule, but not as your ruler. Change your passion, not your pension. And thank you, Namsar, for giving this amazing SN alumni oration and inspiring all of us. And I'm inspired too. And mentioning about teachers of teachers, Dr. Charles Kippen shows your respect for teachers and elders. Salute you, sir, for the oration, and thank Dr. Bishwas and Dr. Mohan Rajan and all the members of Shankarnetra alumni and Arvind. And I'm happy. I just want to finish my thing. I went in Dhoti with Dr. Badrinath to Madurai in 1986. I don't know whether Dr. Namsar remembers. He told, when Dr. Badrinath got down from the train, he told me you have to go to two temples. I said, yes, sir. One is Madurai Meenakshi Amman. What is the other one? I said, he said, Arvind Ayaskurla, of course, he told me. And he directly took me to Dr. G.V. sir's room. And I think Dr. Ram also was there. And then we went for the IMA. So I think I'm happy that Dr. Nam knows me from my childhood because of my grandfather and my origin from Madurai. Thank you very much, sir.
Thank you very much, Nati, for the nice vote of thanks. Sir, once again, we thank you on behalf of the Shankarnetra Alumni Association for taking time off your very, very busy schedule and being here with us and delivering really a fantastic oration, sir. Really, thank you very much, sir. I think you should all give a very big round of applause. Put our hands together for Professor Nam Paramaswamy.
Thank you, Mohan. Thank you, JB. Thank you, everyone.
Thank you.
See, we go on to the Retina capsule now, and over to Dr. LG and Dr. Manoj Khatri.
Thank you so very much, sir. And thank you for the wonderful oration, Dr. Nam, sir. We are truly blessed to have you here with us today evening. As the role has been highlighted, what the mentor can do to shape the future generations. Let me call upon the chairperson for the today's evening's Retina capsule session, none other than Dr. Lingam Gopal, sir. It doesn't require any introduction. Again, teacher of teachers who has taught generation of ophthalmologists and VR surgeons. We also welcome our esteemed panelist, none other than Dr. Pramod Bhinde, sir, Dr. Mahesh Shanmugam, sir, and also Dr. Dhanashri Ratra, madam. So with this, we begin our session with a keynote address, which will be given by none other than Associate Professor Dr. Rupesh Agarwal from Singapore. And as Dr. Nam sir has said that we are looking for people who are coming back to serve the country. We are looking for the time when Rupesh comes back and be us with India rather than working in Singapore. So just a brief introduction about Rupesh. He works at National Healthcare Group Eye Institute of Tentuxen Hospital, Singapore, over a decade now, and is also a consultant at Moorfields Eye Hospital, London. And his recent appointment at SERI, which is a very prestigious appointment at Singapore Eye Research Institute, and one of the head of ocular infections and antimicrobial unit to take care of the research to a different level. He has not many attachments as well, which I'm going to skip due to paucity of time. He will be talking to us on the importance of the art of multinational studies is femto approach. As we all are aware, he has done significant amount of work as far as translational research is going on, and also collaborative studies, including the popular study of eye gates, which was on ocular trauma, OASIS study, which was on autoimmune systemic inflammatory diseases. Also, the COIN study, which was on comprehensive ocular imaging collaborative study, and his great contribution to the work of ocular tuberculosis, which is named as POT study, which JB sir is also part of it. So with these few words, over to you, Rupesh. We are privileged to have you with us and delivering the keynote address, and look forward to your talk. Thank you so much.
I only just want to add one thing for Rupesh, that he's a dynamo and he's the Secretary General of Asia Pacific Ophthalmic Trauma Society and the International Society of Ocular Trauma. Over to you, Rupesh.
Welcome, Rupesh. Thank you very much.
You're muted,
Rupesh. You are muted, Rupesh.
No, still muted.
Yeah. Okay.
Okay.
Sorry. So I'd like to take this opportunity to thank all my teachers. And I think this is really a proud moment for me to present this talk in front of all the teachers, including Professor Nam Paramaswamy, Dr. Biswas, every single teacher who has taught me to come to this journey. So as highlighted by Professor Nam Paramaswamy in his talk, that we all need to get together and do some research, and which has to be generated from India, and there is a need for more clinician scientists. So this is a step towards it. And this talk is not about the data. This talk is about how to do research, how we can all work together. This is all about a different level of mechanism, about what Professor Nam Paramaswamy speak about genetics and all. But for that, we need data. This is about how do we go on and collect the data, and how do we kind of collaborate together. So here are my disclosures. The COVID, as rightly said by someone, has been the great teacher. So what we have been doing, the disasters are collaborating better than we are. So this slide taken up from internet speaks about pandemic, climate, conflict have been collaborating very nicely, and therefore bringing down the economy. And that's the reason why we need to get together. So as we have been talking about the research, so I think it requires a bit of structure, and we all agree that femtosecond is a kind of a very buzzword today in cataract, and a lot of people here all are very fancy about femto. Why don't we apply such of these fancy terms when we do research? So F is something about generating a research question. So it is very, very important that we get our facts right, generate a proper research question, and make sure that we are on the correct track. And that is only possible when you get your facts and the basics right. Second is, a lot of times we are able to do this, but we are not able to execute the project. So you have to have a plan to execute the project, and that is only possible with the mentors like Dr. Lingam Gopal, Professor Nam Perumal Swami, Professor Vishwas, Dr. Natarajan, Dr. Mohan Rajan, Dr. Bhinde here on the group. And that is only possible when we have mentors like this. And the reason why we need mentors is to brainstorm about a study design. How do you want to go about doing a research? Of course, you need a team of all the fellow colleagues, all the people who are there on the colleague, to make sure that we all work together. And eventually, this is where we come to operationalize by presenting our observations, by putting it in onto the publications. And when you get a paper like JAMA, this is the end result of the FEMTO. So today I will be briefly covering some of the topics which I have been doing. Cannot cover in this 15 minutes all the topics, but some of the collaborative studies which has been started here in this part of the world, as very rightly said by Dr. Nam, is that we definitely need to do something which is of Indian origin or of Asian origin. So the prime example is the COTS generated by myself and Professor Vishali Gupta along with the help of Dr. Vishwas. Then a new study which is in competition with Sun classification of uveitis, is OASIS classification. I'll be speaking about it, and a trauma classification called as IGATES, supported by Dr. Natarajan and EFORTS, and it is competing with BATS classification, which has been a very traditional old classification from 1997. And this is a network which we have set up, probably more competent than any network set up by ZEISS. But this is for an open source collaborative platform where Dr. Parveen, Dr. Dhanasri Ratra, and Dr. Rajiv Raman, Dr. Manisha Agarwal, a lot of SN alumni are part of this comprehensive ocular imaging network. So to very briefly mention about the collaborative ocular tuberculosis studies, I will be switching some slides and a little bit of my screen. So this is the new screen. So this is about the collaborative ocular tuberculosis study. And as you can see, this is where we have different phases of collaborative ocular tuberculosis study, where it started with a retrospective study, went on to do a consensus guideline, and eventually now we are at a registry stage. But what this registry has done is we managed to get the people together. We managed to get lots of publications, and this is where the COTS one was about. But very interesting thing is the generation of the group got together to present the consensus guidelines, and what we have come out with is a calculator. As you can see, we have an IOL power formula calculation, but now let's see what happens with this calculator. So this is a COTS calculator, and once you give a phenotype, choroiditis, and you can give a label as tuberculoma, you can give patient is from endemic or non-endemic, whether tuberculin skin test is positive, negative, IGRA is positive, negative, chest X-ray is positive, negative, you get a value of 5. And 5 years stands for more than 80% of the experts will give the anti-tuberculosis treatment. So this is how you can probably bring the research from the bench to the bedside, as Dr. Nam Perumal Swami was saying in his talk. So let's go for talking about another topic, is how the COTS journey was there. So as you can see, the COTS did adopt a FEMTO approach, and the reason was that because we were not aware what we are dealing with TB, is the diagnosis correct, is the treatment correct, and eventually we were not sure about the clinical outcome. And this is a whole group of people we managed to get together from 25 different countries, 100 over collaborators, and this is without any funding at all. So this is not necessarily the money should stop you. And the single question which we wanted to answer was, how do we address the challenges which we meet with TB? And therefore the group was formed, Collaborative Ocular Tuberculosis Study. It went through and we had series of publications. These are just listed 10 publications from here, but very interesting finding was published in JAMA ophthalmology as well as in IOVS and ophthalmology. the interesting phase was when we did a Delphi meeting in Chandigarh, and it was called a Scots Consensus, where a group of people we met together, along with collaborated with International Ocular Inflammation Society, IUSG, and all of us got together along with Foster Ocular Immunology Society to build together towards a better tomorrow. So here, using a Delphi approach, we brought up all the clinical signs, and this is again an approach which we adopted, and it was not something coming from US or UK or anything. This was a very Indian approach which we adopted, and whether the patient is endemic, non-endemic, the disease was recurring, what type of disease was it, and based on the minimum parameters which you can manage in the clinic. And then we generated a question, and some of the researchers, they said this is the longest ever survey they ever did using a 486 questions. And we asked them to give it on a Likert scale. Likert scale was 1, 2, 3, 4, 5, and if they label it as a 5, then that means they are keen to give anti-TB treatment. And when they got a 5, we divided it into further with the different IQR range into 0, 1, 2, and accordingly we decided whether the patient should get an anti-TB treatment or a physician should consider anti-TB treatment. But when the score was 4, it went for a second round of discussion. And these 2 papers were published in ophthalmology, and these have been very highly cited now about the role of antitubercular therapy and when do we start about antitubercular therapy in patients with suspect uveitis. And this is a simple chart which you can keep it in your clinics, and probably you can give an anti-TB treatment based on a very simplistic chart, and this can really help you in your clinics. Along with the calculator, you can have it pasted in your clinic. So this is what we were trying to do, bringing from bench to bedside. So like switching gears from TB, and as some of you must be aware, my fellowship in Shankar Netralaya was on uveitis and ocular trauma. So thanks to Dr. Biswas, Dr. E. Ravindra Mohan, Dr. Uma Shankar, and all my retina gurus, including Dr. Pramod Pindesar, about teaching me about the trauma. From 2001 to 2003, with my pager number 23, I used to be bugging all of you with the trauma cases. But what we have done with this trauma is now we have come up with a new classification called as IGATES, and IGATES stands for this. Okay, this is where an IGATES is. IGATES is International Globe and Adnexal Trauma Epidemiology Study. It involves Asia Pacific Ophthalmic Trauma Society. It involved International Society of Ocular Trauma, Chinese Ocular Trauma Society, Ocular Trauma Society of India, Pan American Association of Ocular Trauma, All India Ophthalmology Society, American Society of Ophthalmic Trauma, and it has resulted into one of the largest ever database for trauma. And this is what we've been able to do using this. Just to give you a quick, how does it help us? So if it is in the clinic, I'm just trying to sign in, and let's just see one of the patients entered from one of the centers. You can even see once the data is entered, a very simplistic format, a baseline, there is a data, follow-up visits, final anatomical, and the visual outcome is there. But what you get here is the ocular trauma score live. As you are entering the data, you can get an injury classification, which is a closed globe injury type, grade, zone, mechanism, and what is the ocular trauma score stands at the baseline, and what is the 6 months outcome or probability for getting a no light perception, hand movement, or vision of 20/40 or more. So this is where trauma thing can help us to move forward as far as this is concerned. If you go and see the collaborations which we have it here, you can see we have almost 39 different sites, starting from Arvind Eye Hospital, Dr. Kim is there, we have from Jakarta, we have Malaysia, we have Gujarat, we have Sydney, we have Colorado, we have Iran, we have Chitrakoot on board, APTO, we have NKP Salve, we have Sakin Singh Hospital from Amritsar, Narayan Netralaya, Bangalore, Aditya Jodh, Shankar Deva Netralaya, National University Hospital, Gangaram, Nepal, and of course, Telangana Institute, MM Joshi, Giridhara Institute. They have already entered 232 records, All India Institute of Medical Sciences, China, and all. So this is a platform which shows the utility of collaboration, and this is where probably we should be kind of thinking about collaborating and taking it forward to the next step and what results you can get. So this is again a screenshot of how you can get it, and again applying a PEMTO approach. And this is a journey of thoughts where different people were involved, and this is all we met at American Academy of Ophthalmology in 2019. started the American Society of Ophthalmic Trauma, which is doing wonders now. And we were able to inspire. And this has resulted into many publications, some publication in ophthalmology as well. And this is the recent paper which just came out, largest ever series of ocular trauma, and presented and called as IGATES. And today only this paper got published in AGO, which is about global current practice patterns for the management of globe injuries, again with all the international collaborators kind of thing. And this would not have been possible without a teamwork. Now, switching back to my Uveitis fellowship, where I used to do the daytime fellowship, and I always have been thinking about the sun classification, which is very predominant, very American, and led by American experts, but we can't translate it into Indian context or Asian context. And that was the reason I came up with this sun classification, or the OSS classification, which is my own kind of thing. And we are now again collaborating here. And here again, you can see we have different users here, and the database is very strong, where you can have entire EMR of uveitis here. But what is interesting here is at the baseline, you can have a summary of working diagnosis, and you can give a diagnosis of anterior uveitis, keratouveitis, intermediate uveitis. Once you click on the diagnosis here, etiological, you can even click under infective, and it can come to all the kind of things. And this is what we need to have when we talk about the biomarkers, whether in the form of proteomics, whether in the form of genetics marker. You need to have this structured data. And without this structured data, whether it is Google or whether it is any big AI company, they cannot do anything. And unless you have a data in a proper format, we will not be able to come up with good, probable, tangible outcomes. And this is where this will lead us to. And we have also designed a widget summary, which will be there. And this will include in coming weeks a sun classification, which will automatically pop up here. And it will be backed up by AI tools, which will be here, where we will be able to calculate the different scores of uveitis here within this database. Again, we have 30 over collaborators here from all over the world, and we are hoping to get more people on the board. So again, going back to my slides about the OSS. So this is how the OSS will run on the back end. Sorry for the poor picture quality. This is an image bank. Also, there is a place for the images which can be added there on the platform. And you have electronic database. This will be entered by ophthalmologist or healthcare person or like optometrist. Eventually, on the back end, we have written the codes which will do the feature extraction from the image, and AI model will be run on the back end to get the features from the images. And we are looking at developing the prediction API, image analysis APIs, and classification API. So this is how an entire thing can be done, and it can be done on a web or a mobile or a device. A lot of you will be surprised that, hey, I need to go to cloud, I need to use AWS, I need to use the Google Cloud platform. So I'll be talking about that in a minute. So just give me a minute how you can overcome the cloud. I know all the regulators have a problem going to the cloud. But before I move that, this is a new topic which I have just picked up in last about 5 years, and this is something in competition with ARI network by Zeiss. And here you can see that what it leads to that here is, okay, yeah, here is comprehensive ocular imaging network, and this is tools developed by us only. These are all original tools where you have a choroidal vascularity index, you have a vitreous age index, and retinal vascularity index. And once you are into this, you will be able to calculate retinal vascularity index in a very interesting way, which I'll be showing in a very different slide. I need to go back to my slide again. Okay. Yeah. So when we talk about the coin, it gives an open source platform for people to upload images, analyze those images, and again come out with the parameters like this. You have an automatically calculated choroidal vascularity index, which I coined in 2015, 2016. But here you can get CVI at different time points, at different spans, and you can do anything. You can change the images, and this can lead to kind of a huge database for choroidal image analysis using the CVI. This is a new tool which we just working with Dr. Natarajan with the COVID patients, and the paper is under review. And here, when you upload a poor quality fundus image also, you are able to calculate the different dimensions from the arteries and the vein And the idea here is to come up with an HPF 24-2. So instead of HPF, the labeling here is RVI. RVI stands for Retinal Vascularity Index, where at different time points, different zones and different topographical distribution, you can calculate what is the thing in a focal ischemia. We have discovered in COVID patients, probably there is some areas of focal ischemia, and this is using this tool. This is a very novel. We haven't yet published any papers from here. But again, where are we heading with all these tools? So interesting word in software imaging is something called as SAMD, software as a medical device. And this is where we are hoping to move forwards, where these kind of tools will be there in your clinics, and at the bedside itself, you are able to analyze the images, and probably this can help you predict the patient's prognosis and all. Now, this is the last slide. Very complex, very technical slide, but very important to understand that it's not necessarily that the data has to go into the cloud. So we are building up a model to data approach where we design the model, and model can come to your clinic and you can deploy this model in your clinic without putting it on the cloud, and the images and the data can be analyzed at source without you having to share the data with giants like Google or anyone. So this is something, a novel approach, where we have come up with a form and you can analyze the data without even sending the data. And this we presented to WHO during the COVID-19 trial, and they really liked it and they are working on it. So to conclude, collaboration is key, and only in this tough time of COVID, if we don't join the hands together, I think we'll be defeated with this pandemic. And world has shown that it was the failure of lack of collaboration. And if we don't collaborate now, I think we are going to head to a failure. And that's why this editorial was orchestrating collaborative research, particularly during the time of COVID, but it has to be done pre-COVID, post-COVID, and with the giants like Shankar Netralaya, Arvind here, I think this is the time where all the people should go hand in hand and join hands together to lead to a better future. Thank you very much for your patience.
Mind-boggling stuff. Rupesh.
I would like to thank Dr. Rupesh for his excellent presentation, a real mind opener for all the youngsters as to how one should plan research, etc. I think his contributions in CVI is very well known, and in fact, he has been able to collaborate with people across the board in using the tool to study many diseases, both retinal and choroidal. I think Dr. Rupesh is a very pleasant person and very friendly character, which is why he's able to bring together a lot of people and be constructive in collaborative studies. Let me tell you, it is not easy to bring together a huge number of people across the world, not just within the country, but outside the country, to be able to collaborate with them on multiple projects and to be able to bring out something useful for the entire society at large is not an easy task. And for that, I would bow my head and I appreciate Dr. Rupesh Agarwal for his excellent contribution. I think he's also been able to tell people how you can understand a disease better by splitting it into small segments, small steps, and try to understand each segment better. And again, there try to come out with standardized nomenclature, and he's able to crystallize the thought process in such a way that a disease which is full of haze, like uveitis, you're able to understand by removing the haze and able to segment it into small areas which are easily understandable. I think I would deeply appreciate the passion with which Dr. Rupesh has put his heart and soul into understanding these very difficult diseases by the special tools that he is developing. Thank you very much, Dr. Rupesh. It was a very good, very impressive talk. Thank you very much.
Congrats, Rupesh. Very good.
Congrats.
Congrats.
Excellent, Rupesh, as usual. Fantastic.
Fantastic.
Thanks.
Mind-boggling
Yes.
stuff.
Mind-boggling.
Sorry, go ahead.
Yes, sir. So brilliant and inspiring, Rupesh, as always, and keep continuing the good work and also collaborating more and more. With this, we thank you once again for your wonderful talk, and also, sparing your Saturday evening, which is a late evening for you right now. Thank you once again. We move on to the case presentations now. First will be by Dr. Sangeet Mittal, who is in news right now with swapping many awards at All India Ophthalmic Society's annual conference. He will be talking to us upon a case of central serous retinopathy masquerades. Over to you, Dr. Sangeet, please.
Thank you, Dr. Manoj. Before I just start, I'd like to thank Dr. JB, Dr. Manoj for giving me this opportunity to present here. It just feels like the SN grand round now, presenting before my teachers, Dr. LG, Dr. JB, Dr. MPS, Dr. PP, all are here. And I hope I do justice to this case. Shall I share my screen now?
Yes.
Please.
Yes, please, go ahead.
Okay. Is my screen visible?
Yes.
Yeah, thank you. So I'm just going to present a case of an 18-year-old female who presented with a sudden decrease of vision for 7 days. And she also complained of mild pain off and on. The best corrected vision was 6/12, and she was referred to the Retina clinic with a diagnosis of central serous retinopathy. And this was her fundus picture. On she had a serous detachment in the macula with the ring reflex, and there was a yellowish lesion just superior to fovea. Autofluorescence showed a patchy hyperautofluorescence, but not very significant. But the main the thing that raised our suspicion was this OCT that we did. The OCT, though showing neurosensory detachment, also showed an abnormal retinal contour. You see the retina was raised here, the contour of the retina as such, or the globe as such, was not normal. So that was the first thing that made us suspicious that this is not actually a CSR, but something else. So we did a FFA. This is a mid-venous phase. It shows a slight stippling hyperfluorescence, which increases in the later phases, increases in the intensity as well as in the size. And this was the ICG, which shows the hypocyanosis all through the early, mid, and the late phases. So we were confused, and there was a lot of differential diagnosis which we had to keep in mind, ranging from amelanotic melanoma, a circumscribed choroidal hemangioma, a choroidal metastasis, a choroidal osteoma, a granuloma, whether tubercular or a sarcoid, a choroidal lymphoma, or a posterior scleritis. So this is a brief chart which shows what the various features of FFA, ICG, OCT, and autofluorescence are in these type of lesions. And the lesions that fit according to the FFA and the ICG and the OCT were amelanotic melanoma, or granuloma, which showed stippled with late increase in FFA and hypocyanosis all throughout. But and definitely posterior scleritis, which does not have any defined FFA or ICG features. We ordered some blood investigations like complete blood count, ESR, routine investigations, want to test VDRL, and these are all within normal limits. We also did a systemic workup like mammography and ultrasound abdomen, just to rule out any primary tumor. A physician opinion was also taken, and an MRI scan of head and brain was done with orbital cuts. On ultrasonography of this lesion, that was also not very classical, but we could make out a thin layer of hypoechoic zone just behind the globe, suggesting a presence of a little bit of fluid in that area. And also there was some elevation of the neurosensory retina here in this area, in the macular area. On the MRI, when we reviewed the MRI pictures of this patient, we noticed the presence of a hypoechoic zone again in posterior to the globe wall in both the T1 and the T2 weighted images. And I remembered I had done a study with Dr. Biswas when I was in SN, and we had done a study on posterior scleritis, and in which we had made a conclusion that CT and MRI could be useful in diagnosis of posterior scleritis, which show this hypoechoic lesion just behind the globe wall. So we made a tentative diagnosis of nodular posterior scleritis, which is very uncommon and often misdiagnosed. The incidence is around 1.5%. It has got a female preponderance and it shows pain on eye movements. 1/3 of patients are less than 40 years of age. 2/3 cases have unilateral involvement, and it is sometimes associated with systemic diseases. The main thing that pointed towards the diagnosis of posterior scleritis was the presence of a small fluid behind the globe wall in the ultrasound, which was suggestive of a T sign, and the presence of a hypoechoic zone behind the globe in the MRI. So we started her on treatment with oral steroids, prednisolone 40 milligrams OD, which was tapered, and immunosuppressants in the form of mycophenolate mofetil 1 gram BD for 2 weeks, and then 500 milligrams BD for 2 weeks. And this was 2 weeks later, the neurosensory detachment has decreased and the contour of the retina has become normal. This is 2 months later, the neurosensory detachment has gone off and the best predicted vision has improved to 6/6. Thank you.
Very nice.
Excellent presentation, Dr. Sangeet. Can I request the panelists to give their opinion on this interesting case? Dr. Mahesh or Dr. Pramod and Dr. Dhanashree?
Thank you, sir. And please go ahead, Dr. Dhanashree.
No, I'm sorry. I had lost the connection and I missed the talk. So please go ahead.
Thanks, Dr. Sangeet, for presenting an interesting case. I think the clue was in the FFA because there was a hot disk. The hot disk indicated that it was an inflammatory pathology. And amylotic melanoma, yes, that's possible. But then, like, the fact is, the ultrasound features were not classic of that, and the hot disk indicated that it was an inflammatory pathology. And even in the OCT, you can see cells in the posterior vitreous. So that again was suggestive of an inflammatory pathology. And only thing is, like in the posterior scleritis, you will see early hyperfluorescence in the form of dots, which subsequently kind of leak. But here, I wouldn't actually rule out a granuloma also, because the kind of the fluorescein which you see was something like a kind of global fluorescein, unless some pictures are missing. The point against this is the fact that, like, the choroid and the sclera appear to be elevated on the OCT. So that kind of indicates more towards a posterior scleritis.
Any other point by other panelists? I think the important point was the cells in the vitreous, which, if they are not intense vitreous haze, we tend sometimes to miss cells close to the lesion, because it's a focal lesion still, probably it's not intense posterior uveitis, may not be there. But with the slit-lamp biomicroscope, when we examine cells close to the lesion, should be carefully looked for. And as Dr. Mahesh very rightly pointed out, the OCT also can detect the cells. That would definitely point more in terms of inflammatory pathology than something like amylotic melanoma or a choroidal hemangioma or even a metastatic tumor. The unifocality goes a little more against metastatic tumor. Not that it cannot be unifocal in a metastatic tumor, but you will see often multiple tumors if it is a metastatic tumor. The ICG, of course, is very, very useful for hemangioma because it should be hypersenescent right in the beginning itself, which is not the case in this case. So I think it's a very illustrative case, Dr. Sangeet. Thank you very much for sharing it.
Thank you, sir.
Can I ask a question, sir? LG, sir?
Please.
So, how about the granuloma, sir? Tuberculosis or a sarcoid?
I think that was also the point which Mahesh was trying to make, right?
Yes.
Is it looked, if you see the OCT, it looked as if the whole choroid and RP is being pushed forwards by something behind, rather than an intrachoroidal lesion.
Okay.
So that is more like, but what can spill over into another thing. It's not that they have, after it's an inflammatory disease, it can definitely spill over into choroiditis, but in this case, probably it is more of a scleritis rather than a choroidal granuloma.
This
Any other point?
was there, and this scleral thickening was also there. Yeah,
Yes,
this scleral thickening was there, and
I think we have not been able to hear you properly, Ms. Vascular.
Maybe some audio problem.
Yeah.
Can you repeat it?
Okay.
All right. Okay.
There.
Please, we go for the next talk. Dr. Manoj, can you introduce the next speaker?
Yes, sir. Next talk will be by Dr. Rupak Rai. He is a faculty of Shankarnetralaya, Calcutta. He will be talking to us on an interesting case of UIM, that is unilateral acute idiopathic maculopathy. As we know, he has done a lot of work on multimodal imaging, and that is one of our favorite topics. So let's hear from Rupak on UIM.
Thank you, Dr. Manoj. I thank SN Alumni for this opportunity, and it's a great honor to present in front of my teachers. I'll be presenting a case of, is my slides visible?
Yes.
Yes, sir.
Yeah, I'll be presenting a case of unilateral acute idiopathic maculopathy. Brief history is a 40-year-old female, case of hypertension, rheumatoid arthritis, presented with sudden complaints of distortion of images and painless diminution of vision in the left eye since 1 week. Patient was not suffering from any prodromal viral flu-like illness. On presenting, the best-corrected visual acuity in the right eye was 6/6 and the left eye was 6/15. Anterior segment was normal in both eyes. The fundus in the right eye was normal. The left eye showed a yellowish area with area of subretinal fluid in the fovea region. On the multicolored imaging, you can see a greenish hue suggestive there is fluid collection. We did a fluorescein angiography. We showed late pooling in the area of the lesion. The interesting finding was of the OCT. This is the OCT of the left eye. This is a subretinal fluid, and this is what we now call as the bacillary layer detachment, or where there is a split in the myoid layer of the retina. So here you can see the subretinal fluid, and this is the area of the bacillary layer detachment. This is again an OCT angiography we did. There were some flow voids in the choroidal slab, and no other abnormality was seen in the OCT angiography. We can see the bacillary layer detachment here. So historically, bacillary layer detachment is described in various diseases where there is primary involvement of the choroid and RPE. Bacillary layer detachment is an OCT finding where there is splitting of the ellipsoid and the myoid rod inner segment was noted at the margin of the lesion. Bacillary layer detachment as a presenting feature in acute idiopathic maculopathy has been reported in 3 cases till date in literature. So this will be the 4th case where we found bacillary layer detachment as a presenting feature of unilateral acute idiopathic maculopathy. So unilateral acute idiopathic maculopathy is an uncommon macro-inflammatory disorder of the RP that affects young healthy males and was first reported by Januzzi. Patients with UIM often present with sudden and severe unilateral vision loss following a viral flu-like illness. There is presenting features could be RP thickening associated with exudative neurosensory retinal detachment and presence of hyperreflective material underneath the detachment. The natural course of UIM is spontaneous recovery. That's happened in our patient also. There was no treatment that was offered. Patient was asked to come back after 1 month, and she came back with the complete resolution of the bacillary layer detachment. So hence, based on clinical history, clinical appearance, imaging findings, and self-limiting nature of the disease, a diagnosis of acute unilateral acute idiopathic maculopathy was made. To conclude, bacillary detachment in UIM is not commonly reported SD-OCT finding and can serve as an imaging biomarker. Thank you very much.
Well done.
I'd like to thank Dr. Rupak Rai for that, for bringing up a very, very interesting disease called UIM. But I'd like to share with you one case which we had here, which presented again with typical subretinal hyperechoic, hyperreflective material on OCT, and visual acuity was not badly affected. The patient is symptomatic because of distorted image, but visual acuity was not badly affected. And this was thought to be UIM by 2-3 of us who have seen along with Dr. Adrian Co also. And Dr. Adrian Co actually made this presentation in the in one of these societies, Macular Society or something like that. And everybody seemed to have agreed with the diagnosis of UAIM because it resolved spontaneously after a period of time. But there was one guy who's I don't remember the name of the person. He said, watch out for lymphoma. And lo and behold, the patient is under follow-up for the last 2 years now. That patch of hyperreflective material kept shifting. As the patient comes, next visit, it shifts to the upper arcade, that goes away, then it goes to lower arcade, etc., etc. And ultimately, we wanted to even do a vitreous biopsy because we did not know what exactly we're dealing with. But by the time we decided to do a vitreous biopsy, because it started developing lesions in the fellow eye as well, but no vitritis at any stage. Then she developed neurological symptoms, and then she was diagnosed as a cranial lymphoma as well. So what I'm trying to say is that don't always think that these are all benign lesions which can go away. Keep a close follow-up on them, because sometimes we can be seeing the early stages of a disease which can develop much later on, much more detail, because at the end of the day, UAIM is a descriptive entity and not an etiological entity. You still don't know what causes it. It's a descriptive entity. So that can actually be something else later on as you follow up the patient. Anybody else like to comment on this? Dr. Mahesh, Dr. Pramod, Dhanashree, or anybody else?
Sir, I would like to ask one question to Rupak. Rupak, a very nice case and very good OCT scans. But if you notice the OCT scan, here also you see that there is a very convex, the posterior border of the eye is very convex, not like normally how you see concave. So did you suspect any kind of retrobulbar lesion in this patient? Which is actually very similar to what Sangeet's case.
Okay, no, I did not suspect that because the predominant lesion was pre-retinal. So I was thinking more in terms of an idiopathic maculopathy. And the patient came back for a follow-up after 1 month and with resolution of the lesion also. So this is one point I did not consider. No, madam.
How much is the follow-up now, Rupert? Total follow-up?
1 month, sir. But I will look into the case.
Just 1 month now.
Yeah, I'll look into the case more closely when the patient comes back, and I also keep Dr. LJ's points in mind that this patient might have some other systemic associations also.
Actually, the case which I was discussing didn't have this kind of a bacillary detachment that you talked about, but it's more of a subretinal, clearly subretinal hyperreflective material, which is what was typically described actually. So that's what he had and she had, and ultimately turned out to be something else. And what you described as bacillary detachment is, again, to me, a little non-specific in the sense, even a VKH syndrome to start with, when there are early features of RPE bumping seen, you can get this kind of a isolated edema in the outer layer of the retina, not involving the entire retina, because it starts with an RPE inflammation. It's only later on that you get cells in the posterior vitreous and the entire retina becoming edematous. This is basically a pocket of inflammatory fluid which is collecting in the outer part of the retina that gives you that appearance, because that is where the inflammation starts. So it still, to me, is a non-specific sign. It's not anything that pinpoints a particular disease process, but it tells you that the inflammation is starting at the RP level. That's why the immediate proximal outer retina is what is showing those widened spaces because of fluid collection, not the entire thickness of retina.
Right, sir.
Do you like to investigate this patient before labeling it as the idiopathic or systemic other issues, or absolutely not necessary? Because though no fever, nothing, I mean, this particular case, there are incidences somewhere like a proposed therapy, like a some viral infection or something that people are, I mean, all these are like proposed hypothesis, but before labeling it as a unilateral, like a idiopathic, do we really do maybe our any or can add on something in that also?
Do you want to answer that, Biswas?
What is the differential diagnosis, sir? Sir, LG sir?
Yeah.
What is the differential diagnosis such a case comes?
No, I don't think we are talking about differential diagnosis in this case, because it's called idiopathic because we don't even know what its cause is.
What Pramod is asking is that only.
Yeah, if there are inflammatory signs, if there are cells developing in the vitreous cavity, then I would go to the direction of trying to exclude an infective etiology. But if there are no cells in the vitreous cavity, which is typical of the UAMs, then you're not talking not of inflammatory pathology, then there's no harm in observing for a few days and see what happens. And if it's trying to resolve by itself, then it's okay. But the case which I was discussing about, we actually give her steroids because her vision dropped. And with steroids, the vision actually improved. And it's very peculiar that the ERG in that case showed actually a more global involvement, while physically and on OCT, we can only see it as a small located lesion, while ERG showed a diffuse decrease in the amplitudes. So indicating probably a lot more etiology than what meets the eye. But I would say you investigate first ophthalmologically point of view. Is it a localized disease or is it a diffuse disease? Is it an inflammatory disease or a non-inflammatory disease to start with? And then on observation, sometimes what looks like a non-inflammatory disease can actually turn out to be inflammatory disease because the cells take time, as I said. See, traditionally we were taught that VKH means there must be anti-segment cells at least. But you can see the earliest case of VKH, there may not be any cells in anti-segment at all, not even one cell you'll see. But as you see the patient, there's develop cells. So I guess follow-up is what is critical before we can think of investigating for a viral infection.
I would rule out TB and sarcoid.
Yes.
Yeah.
I just because.
Sir, one more thing which comes to my mind is these immunoglobulopathies, like this Waldenstrom's macroglobulinemia and all. They also have this deposition of these immunoglobulins in the subretinal space. So if you see, and they are very prone to serous detachments like this. The only thing is it might be bilateral, but to begin with, you may have just one eye involvement. And many times they will come typically like this, a serous detachment with some deposition in the subretinal space with this hyperreflective deposits. And I think it would be
Usually
good
it will
to
be
keep that in mind.
multiple, right?
Yes, yes. Usually it will be bilateral, but in case like you have caught the patient very early before it has started in other eye, maybe good idea to investigate from that point of view as well. Because I have seen one patient like this with a serious detachment on both eyes, and then turned out to have this globulinemia, Waldenstrom globulinemia.
Good.
In case, sir, you would like to add something?
Nothing. I like Dr. Dhanushi was mentioning the choroid appeared elevated to me. So I think it kind of resolved subsequently in the scans. So that is the thing which I was also concerned about.
Do you think it's probably a mild choroiditis which sort of resolved by itself?
Possible, sir, because definitely the choroid was dome shaped. So in multiple scans which Dr. Rupak showed, the choroid was dome shaped, and I think it did resolve subsequently.
Yeah, I don't think that would be a feature of UAM actually.
Yes, sir. Yes.
I think Rupesh is also there with us. Rupesh, you'd like to add something on this case?
Yeah, thanks, Manoj. Dr. Rupak, did we did ICG in this patient, or I have not seen? I saw the FFA.
ICG we have not done.
Okay, so I will say, see, some of these cases I will like to do, and also if you have ERG facilities, we must try and do that. A couple of things on the OCT, just for some of the junior doctors who are attending, and sometimes we don't pay that much of focus of attention. So we're writing up a case, around 15 or 16 cases of UI. We don't have the bacillary, and we're just putting up all these cases of ERGs and all everything together. Now, very interesting finding on the ellipsoid zone and all. You will see a disruption with focal hyperreflectivity there. And I have at least 3 patients in which the entire zone which was disrupted of the photoreceptor ellipsoid zone at the baseline, and over a period of time they resolved and complete structural integrity came back. And then I was discussing this with Professor Graham Holder while we were doing the ERG, also serial ERG, and a very interesting question came up is what is that which changes the OCT layers, like in the first stage, whether it is the inflammation of the photoreceptor, and therefore it becomes distorted. And over a period of time, the inflammation resolves, and then it comes up back to the same structural integrity. So along with that, we did a serial visual field also. The visual field was showing a scotoma, and with period of time, the scotoma also resolved. Very interestingly, some of these patients are really, there are a lot of things to learn from this patient, and they come with a very minor degree of scotoma. What I've started doing is every single patient who comes with this thing, I ask for a few things. I give them the Amsler grade. I ask them to follow it up. They are very, very particular, and then they can come back and on a serial MCLR, you can then monitor. I think some of the things, so serial OCT, probably the MCLR grade can be useful. And if you have a ERG facilities, definitely try and do it. ICT will be useful. Some of the points.
There's
Can
just
I ask a question?
one point, Dr. Rupesh, that the ellipsoid zone disruption is not common even in plain simple CSR as well, where you can see ellipsoid, because what we are looking at is a reflectivity, not really a physical structure there. And the reflectivity, when it gets altered, it looks as if the ellipsoid zone has disappeared totally and it's got reinstated later on. It may not be true. It may actually be that the reflectivity is altered because of the disease process, and so you don't see the individual structures which are all there. It's just that they have to be reconstituted in a way they can be detected by the OCT mechanism. So I think we need to differentiate between a OCT reflected image versus the pathological disruption of ellipsoid zone itself. So even in simple CSR, you can see that sometimes.
Sure.
Can I ask a question, sir?
Yeah, please.
So how early do you expect the UIM lesions to resolve? Means in Rupak's case, we found it as early as 1 month, because I have reported a couple of cases of UAIM where I saw the resolution as early as 5 days post presentation. So how early do you expect it to resolve? Means and what causes this early resolution in UAIM cases without treatment?
Frankly, I have no answer, because I don't think I have that much experience with UAM to be able to tell how early it can form. But your own experience that within 5 days it recovers is a very good point to share with everybody. So if something resolves so soon, obviously that means there is spontaneous resolution is so common that we should not treat that, just observe. But beyond that, I really can't contribute anything beyond what you told. Is there anybody else who has?
How long do you wait for resolution? How long do you wait? Suppose it doesn't resolve after 1 month.
I have asked them to come every week, and if it shows signs of improvement, I have not done anything. But in this particular patient, because the vision dropped precipitously, I actually gave us a course of systemic steroids, and not knowing whether steroids actually have done any good for this patient, because it has come back in another place. So I don't think the steroids did anything for this particular patient. So I guess you are justified in observing as long as things are not becoming worse and things are becoming better. So
if it's not resolving beyond 1 month, is it not that you have to think about an alternate diagnosis?
Absolutely, I agree.
Actually, look at the literature. They have shown somewhere between 1 and 3 months. That's what literature says. But the progressive sign of improvement, I think, and they said up to 3 months. That's what the general course, what is correct, and just ultimately thin layer of RP atrophy, and otherwise vision and all this, even microperimetry studies have also been shown that complete recovery of the function and the disappearance of scotoma. Up to 3 months, that's what is suggested here.
But how long you want to
when
wait?
I was going through some literature.
Depend upon individual improvement. Any other point the panelists would like to make? It's a very, very interesting case and very interesting discussion. Thank you very much, Dr. Rupesh, Rupak, everybody. So let us go to the next case. Dr.
Yes, sir. Thank you, Rupak, for getting such benign looking case and good discussion. And we have to be a little broad in thinking that we should not be missing some of the systemic complications of this benign looking lesion, as Dr. LG sir said. So moving on to the last case of this today's meeting by none other than Ramesh Venkatesh, who is from Narayan Netralaya, Bangalore. As we know, Ramesh has also contributed significantly on multimodal imaging. His work is quite substantial on that. He will be talking to us on sequential RP tears following ranibizumab injections for neovascular AMD. Over to you, Ramesh.
Thanks, Dr. Manoj. And it's a privilege actually to talk in front of all my teachers. And thank you to the SN Alumni team for allowing me to present here. So are my slides visible?
Yes, Ramesh.
Okay.
Go ahead.
So this was a 76-year-old male. He was a known hypertensive, and he presented with a visual acuity of 1/60 in the right eye and 6/6 in the left eye. This was in April 2021. And the right eye basically was lost due to scarred CNVM. That is the reason. And the left eye, he presented with an area of subretinal bleed along the inferior arcade. And there was an area of RP rip, which we could see inferior to the fovea. And there was a PED which was seen temporal to the fovea. So this is how the multicolor image looks, where you can very clearly see that this is a large area of RP rip or RP tear with subretinal bleed.
And on the temporal side, you can see this greenish hue, which is suggested that there is a PED which is present there, and multiple atrophic patches as well. This was the OCT, which suggested that there was this curled up RP, which subretinal fluid, the bare choroid or the bare choriocapillary is visible because of the RP tear. And this is the OCT scans which we did through the RP tear number 1. So this is through the OCT scan, which showed the subretinal fluid and the tear as well. And this is the scan, which the lower scan was through the through the PED, which was present temporally. And you could see that the height of the PED was not very huge. It was around 187 microns. So since we had this thought process that once the RP tear is already developed, the chances of another tear developing is very less. Single-eyed patient with a very good visual acuity with activity on the OCT suggestive that we need to treat this patient. And therefore, we treated this patient with injection Accentrix or ranibizumab, 0.5 milligram per 0.05 ml. And we reviewed this patient after 1 month. And this is what we saw on the OCT, on the multicolor image after 1 month, where you could still see that the visual acuity was 6/6, but the patient had developed an additional RP tear temporarily where the PED was present. And this is the April 2021 image on the left side and the May 2021 image on the right side. So this is now we are showing the scans on the left, which is passing through the second RP tear. And now we are showing another scan on the right side, which is not showing a PED, and it is passing through the superior to the arcade, so through the superior arcade, but there is no PED which is present here. So, so we decided that we'll go ahead with the second injection of anti-VEGF, that was again Accentrix. And this is what we found in June 2021, that is after the second injection. We found that there was a development of the third RP tear, which was along the superior arcade, quite distinct and separate from the remaining 2 RP tears, but all along the same meridian in the same direction. So this was the scan going through the third RP tear, and this is the horizontal scans which are going through that RP tear. So the question was whether when you had activity and you had 2 RP tears, 2 fresh RP tears developing with consecutive anti-VEGF injections, would you consider observation or treatment with another anti-VEGF? What is the risk of developing another RP tear? Whether to change to another anti-VEGF, because in all the 2 injections till now we gave Accentrix or ranibizumab, and if yes, do we need to change the anti-VEGF? So this is where I want to hold my presentation for a minute and take the panelists' opinion.
I think it's very, very interesting case, Dr. Venkatesh. Can I ask Dr. Mahesh, Dhanashree and Pramod to please give their comments?
Can I have a comment, sir?
Yeah, please go ahead.
Ma'am, should I stop
So
sharing the screen right now, or should I just keep the screen on?
Stop sharing the screen, should be easier.
Yes.
Thanks, Ramesh.
This is an interesting case and very unusual to see this kind of sequential RP tears. But as far as your question of changing the anti-VEGF to something else goes, I feel better not to change the anti-VEGF, because the other options that you have apart from Avastin is that you can either use Eylea, aflibercept, or you can use brolucizumab. But both brolucizumab as well as aflibercept are a little deeper acting anti-VEGF. I feel they penetrate deeper and they act more on the RP layer, and probably they might predispose to more RP tear. So maybe good to stick to either Accentrix or Avastin, but not to these 2. And the second is whether to continue anti-VEGF. Now retrospectively looking at the case with such a good vision and a single-eyed patient, probably I would not inject. Maybe just wait and watch and see how the lesion develops. So that's my opinion.
Any other opinion? Anybody else? I have one question. Did you do angiogram at each stage?
No, we did not do an angiogram.
Why? Because my question was, see, usually we realize that a PED ruptures because it is being pulled from one side by a CNVM which is getting scarred, right? But can a PED spontaneously rupture? Theoretically, it is possible. I suppose the very act of giving intravitreal injection itself produces so much fluctuation in the intraocular pressure dynamics, whether that can induce a rupture in a RPE which is has a tendency to rupture, because we have seen huge PEDs not rupturing despite repeated intravitreal injections, while in this case, even a shallow PED started to rupture. I guess that may be individual difference, which I cannot explain. But my question is that, are we dealing with a neovascular disease of sporide, which is causing the PED, or is it just a serous PED without a CNVM? If there's no CNVM, then why treat with anti-VEGF at all? Just because there's a PED, we don't have to inject anti-VEGF, right? You had a bleed. The bleed can occur even due to PED itself, because along with PED, the cochlear capillaries tends to tear, and you can get a small hemorrhage. But what we need to do is we should demonstrate that there is a neovascular process. So I would do definitely an angiogram before I further subject him to do anti-VEGF, when knowing that this particular case seems to be behaving rather bizarre, in the sense it ruptured in one place, which mechanically it seems to have relieved the traction on the pigment epithelium, but at it's rupturing elsewhere. That's very, very bizarre. So in all the more reason I would do an angiogram in this case.
And how do you explain the third RP tear? Because at that point, when there was a small RP tear which developed, there was not even a PD which was present at that point, which was there superior to the arcade.
It's not easy to explain, but having said that, I think intravitreal injection itself is a dynamic process. Whether that can tear a pigment epithelium which is prone to tears, I don't know. It's just, it becomes hypothetical.
But if the RP does not, or if the RP does not harbor a neovascularization in that place, and if we are still giving an anti-VEGF, how do you expect a PED or an RP which does not even have a neovascularization in that place expect to tear out?
Exactly. So what I'm trying to say is that you don't have evidence now for any CNVM, right? Because you have not done the angiogram. So it's very difficult for us to even answer your question, because we don't even know whether at the site of the third PED, was there an adjacent CNVM or not. If there's no CNVM, I have to, by exclusion, I have to understand, when we do an angiogram, there is no CNVM there, it developed at a random place, an RPE rip. I have to assume that it is caused by the mechanical distortion of the globe caused by the intravitreal injection, because there's no other explanation I can give, because I've excluded CNVM by angiogram. But here I'm not able to, because I have not done the angiogram. So the first thing I would do is angiogram. And in fact, if we do angiogram, if at all it is the PED, RP rip has occurred next to an existing CNVM, I have to see something, at least even if it is a partially sort of resolved CNVM, it should still show some amount of staining in the late phase at least. So I would do an angiogram first thing.
So how do you explain the activity or the SRF which is present?
I can't explain, unfortunately, no. But I would, in any case, before starting treatment of even a confirmed case of AMD, before starting first time treatment, I almost always do an angiogram. Even if it may not alter my plan of action in a majority of the cases, it allows me to understand what is happening, and it allows me to understand whether it's a polypoidal disease or non-polypoidal disease, etc., etc. So it gives me a little bit more understanding. You may say, okay, in a majority of cases, your plan of action has not changed, so why do you want to do angiogram? But I think to go in a scientific, rational way, I would prefer to do an angiogram in most of these cases. That can give you a lot more answers.
Okay, sir.
The serous PED, when it ruptures, it can give rise to subretinal fluid. Particularly, we have seen massive, large serous PEDs, when they rupture, they can give rise to subretinal fluid. What happens to choroid? The outer blood retinal barrier is not there, so it leaks from the cochlear capillaries. Then with healing is when it stops leaking. It can be by remodeling, repopulation by RP cells. That's what happens. And the lower two RP tests could be just an extension because it's next to each other. So the superior one, I think there was a serous PED subsequently, isn't it, before you injected?
Yes.
No, the superior one did not even show any irregularity of the RP actually. So that was the most confusing part.
No, what did it show? It showed a serous PED before you injected?
No, it did not show anything. RP was flat there.
Okay.
Can I share my screen back, sir?
Yeah, sure.
Is it visible?
Yeah, it's visible.
Yes, Ramesh. Go back.
Yeah, so look at the right image, sir. The right OCT image, the RP is not showing anything, actually.
No, because this is not going on through the vessel, because I think PED is rupture it here is under the vessel. This is little bit above that. Can you go next one? Yeah, see, this is under the vessel. Your line
No,
is
sir,
going
but it is
above
extending
that.
above the vessel also, isn't it? If we look
No,
at
your
this,
line is above the vessel. Yeah, line is above the vessel. You see, you can go back now.
No, but I have a feeling that they would have scrolled the entire
Yeah,
area.
see, line is above the vessel. It's not showing it is not exactly the same area. Scan is not to the same area.
But the OCT would have scrolled the entire macula. I think he picked up this particular image, but I'm sure if it has shown a PED, would have shown that. Is it true,
sir?
Ramesh?
LG sir, I'm quite confident because I've seen all the scans going through it. So there is definitely not a PED. But what's interesting to be seen is the choroid, which is slightly different.
Yeah, the blood vessels are looking like pachyvessels, but they're not pachyvessels, and it's actually not a pachychoroid. It's like almost like a leptochoroid, but the vessels are dilated. That's something which is different. We can go to the next image. Is it just another continuation of the same RP tear?
No, sir, they are these are isolated RP tears.
No, there is a very small area which is separating the larger temporal one from the superior one, which is beneath the blood vessel.
Yes. So they are isolated, right? It's an island.
Yeah, but it's difficult to make out on this image. There is a possibility whether it was a continuation, because I have seen RP tears extend like this circumferentially. That is something like that, but not like what you have seen. What you have shown.
When I show the autofluorescence image, no, sir, I probably think that will get clarified that it is a separate one.
Possibly, yeah.
Okay, so this is the autofluorescence image. So what we did, like what Dhanashree ma'am said, is that we waited for 2 weeks and we wanted to see what's happening, because whether there is another spontaneous RP tear developing or is it because of the anti-VEGF process. And this is what happened after 2 weeks. So this is before the observation period. And this is after the observation period where you could see the intraretinal fluid and the subretinal fluid accumulating. And this subretinal fluid was not at the area of the RP tear. So this is definitely telling that probably there is now a neovascular process which is causing the SRF. So we went ahead with the third injection of Accentrix again. And this is 1 week post injection Accentrix, because I wanted to see whether there is a fourth RP tear which is developing as early as 1 week, but it did not. And this is how the entire picture is. That is, over the period of 4 months, we could see that the first RP tear, the second and the third one developing, and all are isolated islands of RP tears. So this is where I did not understand the explanation. How did the RP tears develop in my case?
Ramesh, can I give a comment here?
Yes,
my hypothesis here would be that probably it is something akin to what the crunch phenomena, what you see inside the vitreous cavity in the periretinal area. So when you inject an anti-VEGF,
it was the PVD was
no,
already.
I am not talking about the crunch in the retina, but this is happening in the subretinal space where the anti-VEGF is acting. So probably since the vascularity is not too much in your case, as LG sir mentioned, the vascular component is less. Probably it is more of a fibrous component, and even the RP cells, these are the mesothelial cells, and they have this fibroblast kind of characteristics. So probably the RP cells or the choroidal choriocapillaries, the stromal cells, they might have contracted, and that would have caused these RP tears. And if you look at the OCT, which you are showing, the one which goes above can you share your screen again, if you don't mind?
Yes,
the OCT where the third RP tear has developed.
Before the RP tear developed, right?
No, after the third RP tear has developed.
Okay.
No, before. Can you go where you are showing these 2 scans, no, where the scan level is going above the level of the blood vessel?
Yes, ma'am.
Yeah, so if you see in this OCT, this black and white fundus photos, there are some near the lower RP tear, there are some kind of radial lines seen. I don't know if these are there in both these photos, and even the later photos also, these lines are there. Whether they indicate some kind of a radial traction on the choroid and the RPE, that probably needs to be seen. Maybe I would like opinions from others whether what I'm thinking is correct or not.
No, obviously, there is something which is pulling it centripetally towards the macular area, which is the reason why it ripped apart inferiorly and then temporally, and then it is going in a circumferential fashion. It's not going on a totally randomized basis. So that's why I said I would love to do an angiogram in this case. That will give me lots of answers.
LG sir, I had a different theory to this. Can I just share my theory?
Yeah, sure.
So what we know is that when you try to give anti-VEGF injections in a patient with already pre-existing RP tears, you actually see that the area of the RP tear increases by almost 20% beyond. So that means there is some kind of expansion which is happening to the RP after the anti-VEGF is being given. Is that RP expansion which is happening? Is it trying to pull the adjacent RP and then causing the tear? And that is why we have these adjacent RP tears happening after each anti-VEGF injections. Is that a possibility?
You're talking about this specific case, or you're talking?
Yes, this specific case.
That also is sort of hypothetical.
Yes, sir. So, but I had this theory because I can't explain the RP tears happening at all. Means other than the expansion of the RP tear, which happens the 20% area. That is what the papers have suggested, that there's a 2014 article which said that there's a 20% increase in the area of the RP tear following anti-VEGF injections. So when that expansion happens, is it pulling the adjacent healthy RP or the attached RP and then causing a tear?
No, there are reports with basically multilobular RM detachment.
Yes, sir. I gone through that report.
Can I ask?
But I think we are missing something, Dr. Ramesh, because if you see your scans in magnification, actually the RP layer is not all right. You see, there's a lot of granularity within the retina as well as within the RP and the outer retina. So something we are missing. So it could be something like MPGN the patient may have underneath. So if you see the membranoproliferative glomerulonephritis associated drusen kind of a thing. And was his hypertension under control?
Yes, sir. His hypertension was under control. If you remember,
because if you can just put one of your the images and zoom up, even the peripheral image, you look at the outer retina, it's not all right. Look at the RP, it's not all right. There's a lot of dots there. Yeah, the one on the right side, if you can just zoom up,
yes,
can, if any of you have the iPad, you can just zoom it up, and then you can see that it's not a normal looking retina at all. The outer retina is full of dots.
Okay, just, 1 minute, sir. I'll zoom it up again. Just
it's almost like cuticular drusen, but cuticular drusen are much more well defined. But if you see that, it's not all right. Yeah, we can just go to the you see that there's not normal retinal structure at all. You see the outer retina, you can see a lot of dots there.
So you are able to see the zoomed up image, right? Right now?
Yeah. Yes, and even otherwise, I am able to zoom up even without that with my iPad. But then you can see it's not a well-defined retinal layers at all, and it's supposed to be normal retina in that area, isn't it? And you see the outer retina also, and the RP layer is not uniform like a single line. It's
but
like
then
made
this
up of
goes
multiple
against
dots.
all the theories of RP tear where we talk about the height.
No, I see. Like if the theories we are talking about, if it were true, every other patient whom we are injecting with anti-VEGF should be having RP tears, and which should be extending, which is not what is happening. We have treated huge PEDs with anti-VEGF, it doesn't tear, and it doesn't continuously keep on tearing over the next few months. So there is something wrong in this patient which we are not able to identify. That's what I would say.
Okay. Is there anything which I need to image him or work him up for?
Angio. Do an angio.
Okay. Can I ask a question to Ramesh?
Yes, sir.
And LG sir also, and one. The presence of an RP tear, okay, especially this is a one-night patient as well, other is got a scarred CNVM. And is it the red flag sign as far as intravitreal anti-VEGF is concerned? Because the presence of an RP tear already, and it's going to aggravate definitely. Why don't
current recommendation is continue treating.
Continue therapy.
Don't stop anti-VEGF.
The patient has got good vision and 6/6 vision. Why not observation in this case?
So
the current recommendation, we have to do an angiogram first to make sure that there is definitely a neovascular disease, then continue that. Otherwise, not necessary.
So, but isn't the SRF which is developing at a site other than the RP tear any clear-cut indication that there is an activity of a neovascular disease?
I don't think we should assume just based on SRF. And as Ramesh said very clearly, I mean, Mahesh said very clearly, the act of RP ripping itself can liberate a lot of subretinal fluid. So I don't think, I mean, and we have seen a lot of cases of large PEDs, both at the edges of the PED as well as in the top of the PED, you can get a pocket of SRF, but no neovascular process, because those cases all, I angio them and to see, I don't blindly start them with anti-VEGF drugs. These are patients with no complaints, they have a large PED, significant PED. On the top of the PED, you can get a pocket of fluid because the RPE becomes partly dysfunctional. So it's more of a dysfunctional RPE related subretinal fluid and not because of neovascular process. Same way at the edge of PEDs, you can get a pocket of PED of SRF because of mechanical reasons. So those cases, you don't treat them at all. And how do you decide whether to treat or not? By doing an angio. That's why I'm trying to harp on the angiogram, because you have to differentiate clearly, is it a neovascular process or not? Only then you decide whether to continue treatment or not.
Fair enough. ICG would be helpful as well?
Both. Always, for all AMD cases, do FFA and ICG. Then we understand the disease better.
Thank you.
Thank you, sir.
Okay, I think, Manoj, are we going to close shop at this stage, or is there anything else?
Yes, sir. We can close it.
Okay, so in which case, I would like to thank all the speakers. There were excellent presentations. And with all stalwarts as panelists, we have really learned a lot from these three cases. And I'm sure Dr. Mohan Rajan and Biswas would like to organize more such webinars where we can have a small group discussions and learn from each other. Thank you very much for all your presentations. Thank you.
Thank you, sir. We are planning to have an oculoplasty meeting webinar next month, along with the pediatric ophthalmology as well. So every 6 weeks, we are planning to have one Shankar Alumni webinar. We've been doing this for the past almost 16 months to 18 months now. Thank you very much for being here, sir. I know it's a very difficult time in Singapore, but despite that, you spent time with us. Thank you very much.
As I said, I have learned a lot. All right. Really learned a lot. Thank you very much.
Thank you, Dr.
Thank you, sir. Thank you, everyone. Thank you.
Thank you very much.
All credit goes to JB. I think we should all give a big round of applause to JB for completely organizing this event and coordinating with Dr. Nam, everything. And of course, I was playing just second fiddle to JB for this. Thank you very much.
Thank you.
Totally agree. Thank you, everyone. Have a great evening ahead.
Thank you.
Thank you.
Your evening starts now, huh?
Yes, sir. Saturday evening, sir.
Saturday night fever.
Okay.
Bye.
Okay. Thank you. Good night.
Good night, sir.
Thank you. Thank you, Mahesh.
Thank you.
Thank you. Bye, Dr. Mohan. Thank you.
Thank you, Mohan.
Shishir. Rupesh.
Bye-bye, sir. Thank you.
Bye, sir. Good night.